It's time for another warm-up review. Let's get going. What are the manifestations of crest scleroderma? So crest stands for calcinosis, Raynaud phenomena, esophageal dysmotility, sclerodactyly, and then telangiectasias. Next, what is the mechanism of action of the penicillin drugs? Well, it's a cell wall inhibitor, so it binds penicillin binding proteins. It blocks transpeptidase cross-linking of the cell wall, and it can activate autolytic enzymes. So it's basically breaking up that cell wall, therefore it is considered bactericidal. Next, which embryologic structure of the heart gives rise to each of the following adult structures? So smooth parts of the left and right ventricles comes from the bulbous cordus. Smooth parts of the right atrium is the right horn of the sinus venosus. Trabeculated left and right atria are derived from the primitive atria. Trabeculated parts of the left and right ventricles are derived from the primitive ventricle. All right, that brings us to the end of the review. Let's get to that video.
I've decided to bring a little class and a little refinement to the genitourinary system by wearing a tie. I'll bet you feel smarter already. In this video, we're going to talk about some basic renal anatomy. But first, let's talk about renal embryology. The kidney starts off as structures called the pronephros, the mesonephros, and the metanephros. So you have to have those three structures initially, but all three do not make it into adulthood. The pronephros is present at week 4, but then it gradually disappears. The mesonephros basically functions as a fetal kidney during the first trimester, and then it becomes part of the male genital system. And the metanephros gives rise to the adult kidney. It first begins to appear during the 5th week of gestation, and then it continues to grow and develop into the kidneys until well into the 3rd trimester. Now, the caudal end of the mesonephros, the end closest to the feet, develops something called a ureteric bud, and this gives rise to the entire collecting system, from the collecting ducts and the calyces and the renal pelvis all the way to the ureters. This ureteric bud also induces the mesenchymal tissue of the metanephros to differentiate into the renal tubular epithelial structures, such as the nephrons. It's kind of like how the mesodermal notochord induced the ectoderm above it to form the neural tube. So tissues interact with each other and induce the formation of new tissue. If the ureteric buds fail to develop, that means that the collecting system doesn't develop. But it also means that there's nothing to induce the metanephros to develop into the nephrons. So essentially, without ureteric buds, you get bilateral renal agenesis. The kidneys fail to form at all. Now, bilateral renal agenesis results in something called Potter sequence, or Potter syndrome. But it's really a sequence of events. It's called Potter sequence. And Potter sequence is definitely high yield, 3 or 4 stars. Without kidneys, the baby's going to have oligohydramnios. Amniotic fluid is basically fetal urine. So if there are no kidneys, there's going to be no urine, and therefore no amniotic fluid. But amniotic fluid is important. Without amniotic fluid, there'll be pulmonary hypoplasia, and limb deformities, and facial deformities like a flattened face, and also wrinkled skin. Now, obviously this constellation of findings could be seen with any type of severe oligohydramnios. It's not specific to bilateral renal agenesis. And really, the term Potter sequence is kind of an outdated name. That said, there's a mnemonic for the features of Potter sequence which spells out Potter. So P is for pulmonary hypoplasia, O is for oligohydramnios, the 2 T's are for twisted skin, that wrinkled skin, and then also twisted face for the facial deformities. Then the E is for extremities, for the limb deformities such as clubfoot, and R is for renal agenesis, which is potentially a cause rather than a result of Potter sequence. So I find that mnemonic pretty helpful. And one other developmental anomaly to discuss is called a horseshoe kidney, which is also 3 or 4 stars. Horseshoe kidney is where the inferior poles of the kidneys fuse, forming a single kidney in a U shape or a horseshoe shape. And then as this U-shaped kidney ascends from the pelvis during development, it gets kind of hung up under the inferior mesenteric artery and it stays low in the abdomen. So make sure you know that a horseshoe kidney is trapped on the inferior mesenteric artery. The other thing to remember is that horseshoe kidney is associated with Turner syndrome. Let's discuss some basic renal anatomy. So the renal artery brings blood to the hilum of the kidney, and that blood makes its way to the renal cortex out in the periphery where the glomeruli are found. Now, the glomerulus is basically a tangled tuft of capillaries, and it's connected to a higher pressure afferent arteriole, which brings the blood in, and a lower pressure efferent arteriole, which carries the blood away. So the glomerulus accepts the afferent arteriole, and the blood goes through the capillary tuft, and then the glomerulus emits an efferent arteriole. Now the tuft of glomerular capillaries is encapsulated by Bowman's capsule, which I think of as like a little plastic baggie that contains both the glomerular capillaries and the filtrate that comes out of the capillaries. The part of Bowman's capsule that's up against the capillaries forms part of the glomerular filtration barrier. Now if you think way back to the beginning of the course in neurology, we talked about how the blood-brain barrier was made up of 3 layers: capillary endothelium, basement membrane, and the astrocyte foot processes. Well, the structure of the glomerular filtration barrier is very similar. There's the capillary endothelium, which in this case is a fenestrated endothelium, unlike the blood-brain barrier, because here we want fluid to leak out of the capillaries. There's a basement membrane, and in the kidney this is negatively charged in order to keep proteins from leaving the capillaries. And then instead of astrocyte foot processes, you have podocyte foot processes. Those podocytes are part of Bowman's capsule. We call them the visceral layer of Bowman's capsule. So blood flows into the glomerulus in the afferent arteriole, and then it circulates through the capillaries. And while it's there, plasma and electrolytes and urea and glucose and amino acids can all ooze through the fenestrations in the capillary walls and between the podocyte foot processes. And all that fluid ends up inside the baggie that was formed by Bowman's capsule. And we call the inside of that baggie Bowman's space. And from there, this fluid, which we call the filtrate, it's not called the urine just yet, from there this filtrate enters the proximal convoluted tubule, which is the first part of the nephron. Now we'll pick up the flow of the filtrate again in renal 3, and we're going to follow it through the nephron as it turns into urine. Dress appropriately. But for the moment, let's go back to the blood that remained in the glomerular capillary. We said that fluid and glucose and urea and electrolytes can all ooze out of the glomerular capillaries. But bigger things like blood cells and platelets and large proteins, they're too big to pass through those fenestrations, so they stay in the capillaries, along with some of the fluid. And eventually all that stuff exits the glomerulus through the efferent arteriole. Now in the next video we'll talk about some of the things that either vasoconstrict or dilate these afferent and efferent arterioles. But that higher pressure afferent arteriole is pressed right up against the distal tubule of that same nephron. And right there in between them are some cells called juxtaglomerular cells, which means next to the glomerulus. Now this is part of the juxtaglomerular apparatus, or the JG apparatus. The JG apparatus is made up of 2 main cell types. You have the JG cells, which are responsible for secreting the enzyme renin, and you have some specialized sensory cells in the wall of the distal tubule right up against the JG cells called the macula densa, or the dense spot. Now the macula densa senses sodium levels in the distal tubule, and if the sodium level in the lumen of the distal nephron gets too low, the macula densa tells the JG cells to release renin. There are 3 main things that tell the JG cells to release renin. One is beta-adrenergic stimulation. The second one is low sodium in the distal convoluted tubule, which is monitored by the macula densa. And the third one is low pressure in the afferent arteriole of the glomerulus. So the JG cells are actually monitoring the blood pressure, and if the blood pressure drops, that's a signal to release more renin. So renin is going to be released in the presence of high sympathetic tone, or low sodium delivery to the distal tubule, or low renal arterial blood pressure. And renin kicks off the renin-angiotensin-aldosterone system. Renin cleaves angiotensinogen into angiotensin 1, and then angiotensin-converting enzyme converts angiotensin 1 to angiotensin 2. And angiotensin 2 has 2 functions. It tenses angios, so it's a potent vasoconstrictor, and that raises blood pressure. And it also stimulates the adrenals to make aldosterone, and then aldosterone causes sodium and water retention. So if the renal arterial pressure is low, the JG cells will sense that, and they're going to secrete renin. That's going to ultimately generate angiotensin 2 and raise the blood pressure. Or if the macula densa senses low sodium in the filtrate, that means that there's low sodium in the blood. So the macula densa tells the JG cells to secrete renin, which ultimately leads to more aldosterone and more sodium reabsorption. At the distal end of the nephron, the urine is delivered to the collecting system. Leaving the nephron, the urine flows into the collecting tubules, which drain into the medullary pyramids, and then into the renal pelvis, which empties into the ureters. The ureters run retroperitoneally down toward the bladder, and then they join the bladder at the ureterovesicular junction, or the UVJ. And the UVJ is a common site for renal stones to get stuck. You also need to know that the ureters pass under the uterine artery in women, or under the vas deferens in men. I'm sure you remember the phrase, water under the bridge. So the urine is the water, so the ureters which carry that water run under the vas deferens in the uterine artery. And this is important because you need to be sure to correctly identify the ureters during any type of pelvic surgery. say you're doing a hysterectomy. You certainly don't want to ligate a ureter by accident thinking it's the uterine artery. Unlike in anatomy books where the arteries are nice and red and the ureters are gray or brown or whatever, in real life everything tends to be this sort of same pinkish tan color. So it's essential to be able to identify the ureters. Remember, the uterine artery is the bridge, and the ureter is full of urine or water. The water flows under the bridge. Now it's time for the end of session quiz. So pause the video, go through those questions, and then we'll go through the answers together. First question. What artery prevents a horseshoe kidney from ascending in the abdomen? Make sure you know this one. It's the inferior mesenteric artery. Next, what fundamental problem creates Potter sequence? It's oligohydramnios, which is classically from bilateral renal agenesis. And what causes that? Failure of the ureteric buds to form. But the fundamental problem causing all the features of Potter sequence is oligohydramnios. Next, what cell type releases renin? Those are the juxtaglomerular cells, or the JG cells. And the last question, what are the three stimuli that induce renin release? Low renal arterial blood pressure, so low pressure in the afferent arteriole, which is monitored by the JG cells. Low sodium in the distal convoluted tubule, which is sensed by the macula densa. And then the third stimulus is beta adrenergic stimulation, sympathetic tone. Dang it, this thing's broken. I'll see you next time.
Welcome back. Let's go through the answers to the warm-up review. First question, which penicillin drug would you use given each of the following infections? Now keep in mind that these may not actually be the ideal drugs to use for these types of infections, but we're talking about just the penicillin drugs here. So the penicillin drug you would use for a UTI would be amoxicillin combined with clavulanate. For neonatal infections, we would use ampicillin, and usually ampicillin is combined with gentamicin. In cases of syphilis, we use penicillin G. And for Pseudomonas infections, you use a combination of antibiotics, and one of those combinations might be an anti-pseudomonal penicillin, including ticaracillin, carbonicillin, or piperacillin. So again, those are also known as the anti-pseudomonal penicillins. Next question, what are the different classes of antiarrhythmics? The mnemonic you want to remember here is no bad boy keeps clean. Class 1 antiarrhythmics are the sodium channel blockers. Class 2 antiarrhythmics are the beta blockers. Class 3 antiarrhythmics are the potassium channel blockers, and Class 4 antiarrhythmics are the calcium channel blockers. That's it for this question warm-up. Let's move on to the lecture.
In this video and the next one, we're going to be talking about renal function. Now, in this video, we're going to talk about glomerular filtration and glomerular dynamics and renal plasma flow and so on. And then in the next video, we'll look at each individual segment of the nephron and discuss how the nephron turns that glomerular filtrate into urine. So let's start with the different ways we categorize the amount of water in our bodies. This isn't terribly complex, but you just kind of have to memorize these percentages. About 60% of your total body weight is water, and 1/3 of that is going to be extracellular fluid. So the majority of it, 2/3, is intracellular fluid. And of that extracellular fluid, 75% is interstitial fluid, and then 25% is actually circulating in the vessels as plasma volume. That's pretty much it. Another way to approach the same thing is the 60-40-20 rule, which is for total body water, intracellular fluid, and extracellular fluid. Because if 60% of your body weight is water, and 2/3 of that is intracellular, 2/3 of 60% is 40%. So 40% of your body weight is intracellular fluid. And then 20% of your body weight is extracellular fluid. It's all saying the same thing in different ways. Now, what does all that have to do with glomerular physiology? Well, the kidneys are responsible for filtering the blood through the glomerular filtration barrier, but only a small fraction of the total body water is actually found in the plasma. So you need to be really efficient at filtering and cleaning out the plasma that does circulate to the kidney. And when you think about it, not all the blood that goes to the kidney is actually filtered by the glomerulus. A large portion of it is, but some of that blood goes to provide oxygen and nutrients to the tubules. And then the tubules are capable of secreting certain substances into the filtrate. So renal blood flow is going to one of two places, either to the glomerulus or to the renal tubules. Let's talk about why that's significant. First of all, we need to think about renal clearance, which is how much plasma volume that the kidney can clear per unit of time. So clearance is volume per unit of time, milliliters per minute, or liters per hour, or gallons per fortnight, or whatever. Volume per unit time. And to calculate clearance, you use the equation UV over P. Now this cartoon may help you remember that expression. UV, like UV rays in sunlight, over, well, P. UV over P. U is the urine concentration of a particular substance, V is the urine flow rate, and then P is the plasma concentration. So UV over P is the urine concentration times the flow rate divided by the plasma concentration. In the first part of that equation, urine concentration times the flow rate, or UV, that's also referred to as the excretion rate. How much of a substance is being excreted from the body per unit time? 100 milligrams per minute, for instance. Pay attention to the units, milligrams per minute, amount per unit time. Then if UV is the excretion rate and you divide that by the plasma concentration, that's clearance. Milligrams per minute divided by milligrams per milliliter gives these units of milliliters per minute, which again is volume per unit time. So if you had a substance that was filtered by the glomerulus, but then none of it was reabsorbed by the renal tubules, and none of it was secreted by the tubules into the filtrate, that means that the clearance of that substance would be exactly equal to the glomerular filtration rate, the rate at which the plasma filtered through the glomeruli. Well, as luck would have it, there's a polysaccharide called inulin that has these exact properties. It's freely filtered by the glomeruli, it's not reabsorbed by the renal tubules, nor is it secreted by the renal tubules. Inulin stays in the renal tubules. It's neither reabsorbed nor secreted. So if you infused a little IV inulin, then you measured the urine concentration of inulin and the urine flow rate and the plasma concentration of inulin, you could calculate the clearance of inulin, which is UV over P. And since you know that inulin is neither secreted nor reabsorbed by the tubules, you know that the clearance of inulin is entirely dependent on the filtration of inulin at the glomerulus. So the clearance of inulin equals the GFR. Now, what happens when the clearance of a substance is less than the GFR? Well, that means that the substance is filtered at the glomerulus, but then some of it is being reabsorbed by the tubules. It's being taken out of the filtrate and put back into circulation rather than going on through the nephron and into the urine. And what if the clearance of a substance is greater than the GFR? Well, that means that the substance is filtered at the glomerulus, but some of the substance in the blood that goes to the tubules is also being secreted by the tubules into the filtrate. So when the clearance is greater than the GFR, that means you have net tubular secretion of that substance. So even if some of the substance makes it through the glomerulus without being filtered, it still has a chance to get into the urine because the tubules can take that substance out of their own blood supply and then secrete it into the filtrate. So again, that means that the clearance will be greater than GFR. So GFR is similar to clearance. It uses the same units, volume per unit time. And then just for reference, a normal GFR is around 90 to 135 milliliters per minute. I usually just remember 100. Then when we estimate GFR, if the patient's estimated GFR is, say, 50 milliliters per minute, then I know that the patient's GFR is about 50% of normal and that the kidneys are shutting down. But how do we estimate GFR clinically? It's not really very practical to give some IV inulin and measure plasma levels and urine flow rates. That's pretty involved. That's where creatinine comes in. Creatinine is found in the plasma naturally. It's a byproduct of breaking down creatine in the muscles. So creatinine functions very much like inulin in that it's freely filtered, it's not reabsorbed by the tubules, and only a tiny, tiny amount is secreted by the tubules. So instead of going to all the trouble of measuring the clearance of inulin, we can calculate the creatinine clearance, and that's going to be a pretty good estimate of GFR. Now, you don't need to know how to calculate a creatinine clearance for step one, but that's how we use the creatinine clearance clinically, to estimate GFR. Next, let's talk about renal plasma flow. So not all the blood going to the kidneys is going to the glomerulus. The renal plasma flow takes into consideration both the blood going to the glomeruli and the blood going to the tubules. And just like inulin is ideally suited for measuring GFR because it's not secreted, it's not reabsorbed, we use a substance called para-aminohippuric acid, or PAH, to estimate renal plasma flow because PAH is both filtered by the glomerulus and actively secreted in the proximal tubule. So all the PAH that makes it to the kidney is going to end up in the urine and be excreted. So the renal plasma flow rate is the clearance of PAH, or the U of PAH times V, divided by the P of PAH. Now let's talk about filtration. Like I said, not everything that goes to the kidneys is filtered by the glomerulus. The filtration fraction is the portion of blood going to the kidney that's filtered through the glomerulus. So the equation for filtration fraction is GFR divided by the renal plasma flow rate. That's another equation you need to know. GFR over renal plasma flow. And again, clearance of creatinine divided by the clearance of PAH would be a good estimation of filtration fraction. And normally it's about 20%. About 20% of the plasma that's delivered to the kidneys gets filtered by the glomerulus. So, in terms of hemodynamics, what determines the GFR and the renal plasma flow, and therefore what determines the filtration fraction? Well, think about the afferent arteriole. We've mentioned before that prostaglandins are vasodilators. So, prostaglandins will dilate the afferent arteriole. So, if you give NSAIDs and you inhibit the production of prostaglandins, that's going to constrict the afferent arteriole. And obviously, as you do that, you can have less renal blood flow and less GFR. And because both of those factors are decreasing, there's no net change in the filtration fraction. Your filtration fraction will still be about 20%, even though both your renal blood flow and GFR have decreased. Then on the other side of the glomerulus, in the efferent arteriole, the potent vasoconstrictor angiotensin II preferentially constricts the efferent arteriole. So constriction of the efferent arteriole is going to cause a back pressure into the glomerulus. You have some congestion of the blood in the glomerulus. And as a result, the overall renal blood flow decreases, but relatively more plasma is going to be filtered, so the GFR increases somewhat. If the afferent stays open but the efferent clamps down, the plasma coming into the glomerulus is looking for a way out, so more of it's going to ooze through that glomerular filtration barrier. So GFR goes up and filtration fraction goes up. Now ACE inhibitors do the exact opposite, since they decrease the amount of angiotensin II. So ACE inhibitors will relatively dilate the efferent arteriole, so filtration fraction decreases. Let's look at this in your study guide. It says, how will each of the following affect GFR, renal plasma flow, and filtration fraction? So take a moment or two and try to reason through these, and then we'll go through them together. The first one is constriction of the afferent arteriole. So this would cause the GFR to decrease, and then the renal plasma flow will decrease, and filtration fraction will have no change. We talked about that. Constriction of the efferent arteriole, again, this is what angiotensin II does. So GFR would increase, renal plasma flow would decrease, and filtration fraction would increase. Then dilation of the afferent arteriole will cause an increase in GFR, increased renal plasma flow, and no change in filtration fraction. Dilation of the efferent will decrease GFR, increase renal plasma flow, and decrease filtration fraction. Now, increase in serum protein. Let's think about what's going on here. With higher protein content in the blood, that osmotic load of the protein is going to keep fluid in the vessels, so less plasma is going to escape. So an increase in serum protein will decrease GFR for that reason, but it's not going to do anything to the renal plasma flow. So the net result here would be to decrease the filtration fraction. Now, what about a ureter stone obstruction? So if you obstruct a ureter, then urine is going to back up into the kidneys and into the renal tubules. You're going to get a back pressure all the way up into the glomerulus. And if you can imagine a high hydrostatic pressure inside Bowman's capsule, that's going to favor blood staying in the capillaries rather than being filtered. So GFR will go down. Now the renal plasma flow won't change, so as a result, the filtration fraction will decrease. Now ACE inhibitors inhibit the constriction of the efferent arteriole. So by inhibiting the constriction of the efferent, the renal plasma flow increases. But as a consequence of this, the GFR decreases. So although you're improving renal plasma flow, you're actually decreasing the filtration fraction with an ACE inhibitor. This is why when we start a patient on an ACE inhibitor, the serum creatinine goes up just a little bit at first, because the GFR is slightly worse. So it's healthy for the kidney to have more blood, but it's not necessarily healthier for the body as a whole because the kidneys aren't filtering the blood as well as they used to be. And then NSAIDs are going to constrict the afferent arteriole, and that's going to decrease renal plasma flow, decrease GFR, and have no change on the filtration fraction. All right, we're almost finished. Just a few more equations to be aware of. If you're looking for the filtered load of a substance, it's the GFR times the plasma concentration of that substance. We talked earlier about the excretion rate. It's the top of the clearance equation. It's U times V, urine concentration of that substance times the urine flow rate. And so what's reabsorbed is everything that's filtered minus everything that's excreted, because the only thing you'd have left would be the things that would be reabsorbed. And then secretion is everything that's excreted minus everything that's filtered. Then what about the clearance of things that your body doesn't want to excrete, that it would prefer to hold on to, like glucose or amino acids? Well, both glucose and amino acids are freely filtered, so in order to hold on to them, they have to be reabsorbed by the renal tubules. As long as the plasma glucose stays in the normal range, your kidneys are perfectly capable of reabsorbing all of that filtered glucose. There's a sodium-glucose cotransporter in the proximal convoluted tubules that takes care of this. So the proximal tubules are the workhorses of the nephron. They reabsorb most everything. But if the plasma glucose gets above about 160, you start to exceed your body's capacity to reabsorb glucose, and you start to lose some glucose into the urine. And then at a plasma glucose of 350, those transporters are fully saturated, so you're going to be spilling out a lot more glucose in your urine as you approach that serum level of 350. Then in terms of amino acid clearance, there are sodium-dependent transporters for amino acids in the proximal tubule as well. There are 3 distinct carrier systems for positive, negative, and neutral amino acids. And one of the problems you can see is something called Hartnup disease, which is due to a deficiency of the transporter for neutral amino acids, particularly tryptophan. So if you don't have tryptophan, you can't make niacin. If you don't have enough niacin, then you're going to have the 3 Ds of pellagra: dermatitis, diarrhea, dementia, and then possibly the 4th D, which is death. All right, that's it for the glomerulus. In the next video, we're going to move out of the glomerulus and start looking at the different segments of the nephron in detail, starting with our workhorse, the proximal tubule. But first, let's go ahead and work through the end of session quiz and go over those answers. First question. A 40-year-old woman weighs 100 kilograms. What is her estimated plasma volume? Well, remember that a liter of water weighs 1 kilogram, and the extracellular fluid is about 20% of the patient's weight. So this patient's extracellular fluid is 20 liters. But of that 20 liters, only 25% is plasma. So the patient's plasma volume is 5 liters. Next, what effect will a renal stone that obstructs the ureter have on GFR and filtration fraction? Well, this is going to decrease the GFR and decrease the filtration fraction. Next, at what glucose concentration is the tubular reabsorption of glucose maximized? Well, you're going to start to spill glucose at around 160 to 200 or so, but the transporters become saturated at about 350. So tubular reabsorption is maximized at a serum glucose concentration of approximately 350 milligrams per deciliter. Next, what vitamin deficiency results from Hartnup disease? Hartnup disease is a deficiency of tryptophan, which leads to niacin deficiency. And don't forget that niacin is also called vitamin B3, and deficiency of niacin is called pellagra. Next, what substances can be used to estimate GFR? Creatinine and also inulin, but creatinine is the one that we use most often clinically. Then what about estimating renal plasma flow? Well, you can use PAH, which is para-aminohippuric acid. Next, what is the equation for the renal clearance of any substance? It's UV over P. Urine concentration of the substance times V, or the urine flow rate, divided by the plasma concentration of that substance. That's it for now. I'll see you next time.
Hello everyone, it's time for another warm-up review. Let's get going. What condition is suggested by each of the following findings? So first we have gout, intellectual disability, and lip biting. That's going to be Lesch-Nyhan syndrome. Antihistone antibodies. That's going to be associated with drug-induced lupus. Renal failure and lytic bone lesions on x-ray. That's going to be seen with multiple myeloma. Next, Streptococcus pyogenes produces which toxins? So let's talk about several of them here. First, there's streptolysin O, which causes hemolysis on blood agar plates. It's going to be oxygen labile. There's also streptolysin S. That's going to be an oxygen stable one. There's also streptococcal pyrogenic exotoxins type A, B, and C. They're also known as erythrogenic toxins. Remember, these act as superantigens and are associated with the red rash and fever of scarlet fever. And then streptococcal toxic shock syndrome. Next, what is HUS? So this is hemolytic uremic syndrome, and it's associated with E. coli, the O157H7, one of the serotypes of E. coli causing bloody diarrhea. With HUS, there is hemolytic anemia, thrombocytopenia, and acute kidney injury as well. All right, that's the end of the warm-up. Let's get to that video.
In the last video, we discussed the physiology of the glomerulus. Now we're moving from the glomerulus into the nephron. We're going to examine the major parts of the nephron one by one. Different parts of the nephron do different things in terms of reabsorption and secretion and concentrating or diluting the filtrate. So in your study guide, we have illustrations for each segment of the nephron to help you visualize what's going on. Now, when you leave the glomerulus, the first part of the nephron you enter is the proximal convoluted tubule. The filtrate that enters the proximal tubule has lots of stuff in it. It's fresh out of the glomerulus, so it has lots of electrolytes and glucose and amino acids and stuff in it. So the job of the proximal tubule is to reabsorb as much of that as possible. That's why we call the proximal convoluted tubule the workhorse of the nephron. All of the glucose and amino acids are reabsorbed here. We covered that in another video. About 2/3 of the fluid and 2/3 of the electrolytes that were filtered by the glomerulus are also reabsorbed by the proximal tubule. And the fluid that's reabsorbed here is reabsorbed isotonically. The electrolytes are reabsorbed and water just follows. So let's look at this diagram. Now, this is the most complicated diagram. They get easier after this. Just bear with me for this one. Over here on the left side is the lumen of the tubule. It's yellow. I'll let that sink in for a moment. Yellow fluid in the kidney. Right. Then, in the center of the diagram is the tubule cell, and the interstitium is on the right. So make sure you stay oriented as we go through these. The lumen is always on the left. Over on the right, moving from the tubule cell and the interstitium, you can see everything that's being reabsorbed from the filtrate and eventually put back into the circulation. So what are we reabsorbing here? Primarily bicarb and sodium. Now, how is bicarb reabsorbed? Well, if you look inside the cell, you see carbonic anhydrase, which is creating bicarb from CO2 and water. Where does that CO2 and water come from? It comes from the lumen side. Bicarb in the filtrate is bound to hydrogen ions that come out of the cell, and that creates CO2 and water, which can move freely into the proximal tubule cell. Then carbonic anhydrase in the cell can convert that back to bicarb, which generates a hydrogen ion. That hydrogen then goes back into the lumen on the left. And over on the right, the bicarb is reabsorbed into the interstitium. And what's driving this reabsorptive process? Well, ultimately it's what drives everything in our bodies. It's the sodium-potassium ATPase up at the top right. Sodium-potassium ATPase uses energy to pump sodium into the interstitium against its concentration gradient. Now toward the bottom, you see that substance X is reabsorbed by a sodium cotransporter. And then X is crossing onto the interstitium side over on the right. Well, what's substance X? Well, it could be a lot of different things. It's your glucose, amino acid, inorganic phosphate, and lactate reabsorption. They're all driven by this sodium gradient. While we're here in the early part of the proximal tubule, let's look at the relative concentrations of all these things as they're reabsorbed. Take a look at this graph in your study guide, and you're going to fill in the labels as we walk through it. The x-axis is the distance along the proximal tubule. So over here at the y-intersect, you're at the beginning of the proximal tubule, just outside the glomerulus. And on the far right of the x-axis, you're at the distal end of the proximal tubule, the beginning of the descending limb of the loop of Henle. The y-axis is the ratio of tubular fluid to plasma. So for any given solute you want to graph, the y-axis is the concentration of that solute within the tubular fluid in the lumen of the proximal tubule, divided by the concentration of that solute in the plasma. So if the concentration of the solute is the same in both the tubular fluid and the plasma, that ratio on the y-axis will be 1. In other words, the solute and water are reabsorbed at the same rate, and the relative concentrations aren't going to change. Now for solutes that fall below that line, the concentration in the tubular fluid is less than the concentration in the plasma, and the ratio is less than 1. That means you're taking solute out of the tubular fluid, out of the lumen, and putting it into the plasma. So you're reabsorbing it more quickly than you're reabsorbing water. Then above that line, that ratio is greater than 1, which means that the solute is being reabsorbed less quickly than water. So you're pulling water out of the lumen, but the solute is staying in the lumen. There's a net excretion of the solute here. So let's talk about what substances follow this pattern. The reabsorption of sodium and potassium aren't changing much from beginning to end, and osmolarity doesn't change much from the beginning to the end. They're pretty flat. You are reabsorbing sodium and potassium, but water is being reabsorbed at the same rate. It's isotonic reabsorption here in the proximal tubule. The relative concentration is staying constant. Bicarbonate is being reabsorbed more than water. The concentration of bicarb in the plasma is rising relative to the concentration of bicarb in the tubular fluid. So the kidney is actively pulling bicarb out of the tubular fluid and pumping it into the interstitium and then into the plasma. Likewise, amino acids and glucose are also plotted down here. These are things that your body wants to retain much more than water. Then up top, what kinds of things does your body value less than water? Well, chloride is above the line. Urea is above the line. Both creatinine and inulin are filtered, but they are not reabsorbed. And since only minuscule amounts of creatinine are secreted, its graph is going to be virtually identical to the graph for inulin. Whatever inulin and creatinine get filtered by the glomerulus is exactly how much is going to end up in the urine. No more, no less. So the concentrations are going up, not because creatinine and inulin are being secreted, but because water is being reabsorbed and the concentrations of these substances increase. So any substance that graphs above that creatinine-inulin line is not only not getting reabsorbed, it's actually being actively secreted into the tubule. That's why PAH has a higher concentration as you get farther along the tubule than either creatinine or inulin, because because PAH is both filtered and actively secreted by the proximal tubule. Now, this is definitely an important topic to know. Be able to look at this graph and label the substances on the graph. A student sent us a mnemonic for the order of these substances above the osmolarity line, which is plasma concentrations increase unless cleared by the kidneys, which stands for PAH, creatinine, inulin, urea, chloride, and then K for potassium. And the Cl in cleared stands for the Cl in chloride. Next, let's talk about the second half of the proximal tubule. The second half of the proximal tubule is a little bit different than the first half. In the first half, sodium absorption was associated with bicarb absorption. But in the second half of the proximal tubule, sodium absorption is associated with chloride reabsorption. So you can see sodium being reabsorbed, and you see chloride being reabsorbed. And that's pretty much it for this diagram. I told you they get simpler after that first one. And you see again that sodium and chloride reabsorption are driven by the sodium-potassium ATPase. Then the next diagram deals with the active secretion of organic cations and anions in the proximal tubule. To secrete an anion, you use alpha-ketoglutarate. So we're starting on the right this time in the interstitium. Alpha-ketoglutarate is brought into the cell with sodium by way of a sodium gradient that's established by the sodium-potassium ATPase. So alpha-ketoglutarate goes into the cell, and then you can exchange alpha-ketoglutarate for an anion, and that anion then goes into the lumen. At the bottom, you see how cations are reabsorbed. There's a net excretion of cationic electrolytes because you're pushing out 3 sodiums for every 2 potassiums that come. And that net excretion of cations sets up an electrochemical gradient, which allows organic cations to move into the cell, down the gradient. And then those cations are secreted into the lumen by exchanging them for hydrogen, for bringing hydrogen into the cell. So that's how cations and anions are actively secreted in the proximal tubule. That's it for the proximal tubule, our workhorse. It's pretty much all downhill from there. The next part of the nephron is the loop of Henle. So there's a descending limb and an ascending limb. There's not much to say about the descending limb, except that the thin descending limb is the part of the loop of Henle responsible for water reabsorption. The thin limb is impermeable to sodium, but the interstitium down there in the medulla is hypertonic, so water follows that osmotic gradient and leaves the thin descending limb, and then the luminal fluid becomes more and more concentrated. Now let's look at the thick ascending limb of the loop of Henle. The thick ascending limb is the site of the sodium chloride potassium cotransporter at the top left. You're actively reabsorbing sodium, potassium, and chloride. Now back in the proximal tubule, it was more of a passive thing. Sodium came in with bicarb, sodium came in with chloride. But here in the ascending limb, you see that this is more of an active process, and you're actively reabsorbing sodium, potassium, and chloride. And the reason that the interstitium in the medulla of the kidney is so hypertonic is because all these electrolytes are being reabsorbed and put into the interstitium. There's a question in the study guide that says, what class of drugs inhibits the sodium chloride potassium symporter, or cotransporter, in the thick ascending limb? Now this is definitely important to know. This is the mechanism of action of loop diuretics. In the next video, when we discuss diuretics, we'll see that loop diuretics cause an isotonic water excretion. So what else is going on in the thick ascending limb? At the bottom of the diagram, you see the divalent cations, calcium and magnesium coming in. They don't come in through the tubular cells, they sneak in between the cells. This is an induced reabsorption of magnesium and calcium. And one thing you also see about the thick ascending limb that you can highlight on the lumen side is that it's impermeable to water. The thick ascending limb is impermeable to water. But even though the tubular cells are impermeable to water, because you're reabsorbing all those cations, sodium, potassium, calcium, magnesium, what's happening to the urine concentration? Is the filtrate becoming more concentrated or less concentrated? Well, the filtrate's less concentrated, right? You have fewer ions, so the filtrate is less concentrated. Or another way to say it is that it's more dilute. So the thick ascending limb is diluting the urine. So again, the 3 things I want you to know about the thick ascending limb. It's impermeable to water, calcium and magnesium are reabsorbed here, and the sodium chloride potassium symporter is inhibited by loop diuretics. Now, once the filtrate leaves the loop of Henle, it enters the distal convoluted tubule. And here we have to talk about the early part of the distal tubule and the late distal tubule. In the early distal tubule, there's active reabsorption of sodium and chloride. The early distal tubule is generally impermeable to water, not always, but generally. But the main thing I want you to know is that calcium reabsorption in the early distal tubule is under the control of parathyroid hormone. There are three main mechanisms by which PTH raises serum calcium levels. It stimulates bone reabsorption, it stimulates the renal activation of vitamin D, and it stimulates renal reabsorption of calcium. And this is where that takes place, in the distal convoluted tubule. Make sure you know that. Now we're ready to move from the distal convoluted tubule to the collecting tubule. Now that name, collecting tubule, is a little bit misleading because it sounds like all we're doing is collecting the urine, but that's not at all true. There's a lot of action taking place in the collecting tubules. So before we get to the diagrams, let's look at the question that says, what two types of cells compose the collecting duct and the last segment of the distal tubule? And what do they do? Well, there are two types of cells here, principal cells and intercalated cells. So the principal cells have two main functions. They reabsorb water and sodium, and they secrete potassium. Then the other cell type is the intercalated cells. Intercalated means inserted or stuck in between. So the principal cells make up most of the collecting tubule, but then inserted in between those principal cells you have intercalated cells, which have two functions: to secrete either hydrogen or bicarbonate and to reabsorb potassium. So that means there are two populations of intercalated cells. There are alpha cells, or A cells, which secrete hydrogen ions, and there are beta cells, or B cells, which secrete bicarb. You can remember B for bicarb or B for base. So some intercalated cells secrete hydrogen, others secrete bicarb. Now there are diagrams of both a principal cell and an intercalated cell in your study guide. We're going to look at the principal cell in just a second, but first let's take a look at the intercalated cell. Over here on the left is a hydrogen-potassium exchanger, which allows the cell to secrete hydrogen ions and to reabsorb potassium. So, what type of intercalated cell is this? Is it an alpha cell or a beta cell? It's an alpha cell. A for alpha, A for acid. Now, before we look at principal cells, what determines how much water is reabsorbed in the distal tubules and the collecting ducts? This is also very important to know. It's ADH, or antidiuretic hormone, which is also called vasopressin. So this is the diagram of the principal cells, and for the moment I just want you to focus on the bottom half of the cells. ADH, or vasopressin, acts on V2 vasopressin receptors on the principal cells of the collecting tubule, and that tells the cells to insert water channels called aquaporins into the luminal surface of the cell, and those water channels allow water to be reabsorbed. Now, this should look somewhat familiar to you. We mentioned this back in psychiatry because there's a drug we use for bipolar disorder that blocks the function of these aquaporins. Do you remember what that is? Lithium. Lithium enters the cell through the sodium channels because remember, sodium is right under lithium in the periodic table, so they're chemically very similar. So lithium enters through the sodium channel and it interferes with the aquaporins. We're going to see that again when we talk about diabetes insipidus. So again, aquaporins are water channels that allow water to be reabsorbed. This means that the distal tubule and the collecting ducts are mainly responsible for concentrating the urine in response to ADH. The thick ascending limb dilutes the urine by reabsorbing lots of sodium and potassium, and then the distal tubule and the collecting duct concentrate the urine. Now we're ready to look again at the top half of this cell. Again, the functions of the principal cells, in addition to reabsorbing water, is to reabsorb sodium and to secrete potassium. And here at the top, you see the two channels that make that possible. So what class of diuretic directly affects principal cells? It's the potassium-sparing diuretics. Lots of diuretics cause loss of potassium and hypokalemia, but these don't. They're potassium-sparing. If you inhibit potassium secretion in the principal cells, you're going to have less potassium loss. Now, not all potassium-sparing diuretics are created equal. We're going to talk about these more in the next video when we talk about diuretics, but spironolactone and eplerenone are aldosterone antagonists that are classified as potassium-sparing diuretics because they do prevent urinary potassium loss. But the other potassium-sparing diuretics, triamterene and amiloride, work by inhibiting the epithelial sodium channels in the collecting tubules. They do not antagonize aldosterone. So the last question before we get to the quiz says, what effect does aldosterone have on the principal cells and the intercalated cells of the collecting duct? You can see this back on the diagram. In the principal cells, aldosterone causes reabsorption of sodium and secretion of potassium. Aldosterone causes your body to retain sodium and retain water. And at the same time, you're secreting potassium. So if you have hyperaldosteronism, you're going to get hypokalemia, plus a little hypertension because of retention of sodium and water. And if you were to inhibit aldosterone with an aldosterone antagonist, this might cause some hyperkalemia. And then in the intercalated cells, aldosterone stimulates secretion of hydrogen ions. Now it's time for the end of session quiz. Some of these quiz questions are going to look extremely familiar because we want to make sure you've really mastered this before we move on and start talking about the diuretics and how they work in more detail. So answer these questions and then we'll go through them together. First question, what segment of the renal tubule matches each of the following statements? The first bullet says reabsorbs 67% of the fluid and electrolytes that are filtered by the glomerulus. That's the proximal tubule. The site of secretion of organic anions and cations is also the proximal tubule. Always impermeable to water is the thick ascending limb. Permeable to water only in the presence of ADH is the late distal tubule and also the collecting duct. The site of the sodium chloride potassium cotransporter is the thick ascending limb. The site of isotonic fluid reabsorption is the proximal tubule. The site responsible for diluting urine is the thick ascending limb. The only site where glucose and amino acids are reabsorbed is the proximal tubule, and water reabsorption in the loop of Henle takes place in the thin descending limb. Next, what are the two main cell types of the collecting duct? You have the principal cells and the intercalated cells. Next, what drugs antagonize aldosterone's action on the principal cells of the collecting duct, thereby promoting sodium excretion and inhibiting potassium excretion? These are the aldosterone antagonists, which are spironolactone and eplerenone. And the last question, what class of drugs inhibits the sodium chloride potassium symporter in the thick ascending limb? It's the loop diuretics. And that's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. First question here, which bacteria secrete enterotoxins? So first we have Vibrio cholera. We also have enterotoxigenic E. coli. So that's making a heat labile toxin that causes similar diarrhea to cholera. Staph aureus has a series of enterotoxins. Shigella, Yersinia, Clostridium species, specifically Clostridium difficile, and also Clostridium perfringens. Next, what is Charcot's neurological triad? So Charcot's triad is associated with multiple sclerosis, and it consists of scanning speech, intention tremor, and nystagmus. Next, what causes subacute endocarditis? So we have viridin streptococci, we have enterococci, and then sometimes coagulase negative staph, specifically staph epidermidis. All right, that's it for the review. Let's get to the video.
In this video, we're going to talk about diuretics. But first, you want to hear a nephrology joke? Well, you're in luck. Get it? You're in luck? Anyway, the other day I found Dr. Lewis just staring intently at this can of orange juice for like hours and hours and hours. And I asked him, what are you doing? He said, well, the label on the can says concentrate. On that note, let's concentrate on diuretics. You need to be able to identify different drugs based on what type of diuretic it is, and you need to know the mechanism of action of each one and exactly where in the nephron the different classes of diuretics work. So we're going to group the diuretics by their sites of action within the nephron, from proximal to distal. So the most proximal part of the nephron is the proximal convoluted tubule. And the diuretic that works here is acetazolamide. So acetazolamide is a carbonic anhydrase inhibitor. Remember, carbonic anhydrase in the lumen of the proximal tubule converts bicarb to CO2 in water, which could be reabsorbed. And if you inhibit carbonic anhydrase, you can't reabsorb bicarb, so you excrete it in the urine. So acetazolamide does have a minor diuretic effect, but we mainly use it not for its diuretic properties, but to facilitate the excretion of bicarbonate. So when would you want to excrete bicarbonate? Well, one condition is altitude sickness. Think back to the pulmonary video on high altitude medicine. If you're at high altitude, the partial pressure of oxygen is lower, so you have to breathe faster and deeper in order to oxygenate the body. So you're increasing ventilation. Now, when you increase ventilation, you're blowing off more CO2, and that leads to respiratory alkalosis. So eventually, over time, your body's going to compensate for that respiratory alkalosis by getting rid of bicarbonate. But that can take several days. So if you have a patient with altitude sickness, you can give acetazolamide to help them excrete bicarbonate and overcome this respiratory alkalosis much more quickly. We can also use acetazolamide to alkalinize the urine, because all that bicarb in the urine makes the urine more alkaline. Or we could use it to treat metabolic alkalosis and help the body get rid of bicarb that it needs to get rid of. We also use acetazolamide to treat glaucoma, because bicarb production draws water into the eye to form aqueous humor. So blocking bicarb production reduces production of aqueous humor. That's going to reduce the intraocular pressure. And acetazolamide is the first-line treatment for idiopathic intracranial hypertension, or pseudotumor cerebri, because it reduces the production of CSF as well. Then for the side effects, acetazolamide can cause metabolic acidosis. Even if you're using acetazolamide eye drops for glaucoma, it can still cause metabolic acidosis. You're losing bicarb in the urine, you're becoming acidotic. Then it's also a sulfa drug, so it can lead to sulfa allergy. So if you have a patient with a sulfa allergy, you don't want to give them acetazolamide. Now, lots of different diuretics are sulfa drugs, so you're going to need to pay attention to that. Next up is mannitol, which also works in the proximal convoluted tubule. Mannitol is an osmotic diuretic. Mannitol causes an osmolar load that stays in the filtrate and prevents reabsorption of free water in the proximal tubule. So it causes excretion of free water. Now obviously mannitol will raise serum osmolarity, but what does mannitol do to the serum sodium? Well, if you're losing free water, serum sodium is going to rise a little bit. Now in terms of side effects, mannitol can cause dehydration because you're losing a lot of free water, and it's contraindicated in patients with anuric renal failure patients who don't make any urine. It's also contraindicated in patients who have congestive heart failure. Now we don't use mannitol very often. Occasionally you'll see it used to treat shock or drug overdose. Sometimes we use it to lower intraocular pressure in patients with acute angle closure glaucoma. You wouldn't want to treat chronic open-angle glaucoma with mannitol, but you might give IV mannitol for acute angle closure glaucoma. So remember, there are two diuretics that can be used to treat glaucoma, acetazolamide and mannitol. And sometimes we use mannitol to treat elevated intracranial pressure, not really because of its actions in the kidneys, but because of its actions elsewhere. So you give IV mannitol, and it goes into the circulation, and it draws interstitial fluid into the vasculature to balance that intravascular osmolar load. So fluid's going to shift out of the swollen brain and into the vasculature in a patient with elevated intracranial pressure. The next group of drugs is the loop diuretics, which includes bumetanide, ethacrenic acid, furosemide, and torsemide. Now of these four, furosemide is the most commonly used one. The brand name for furosemide is Lasix. And you should know that furosemide, bumetanide, and torsemide are all sulfonamides, so you can't give these to patients with sulfa allergies. But ethacrenic acid is not a sulfonamide, so it's the one loop diuretic that's safe in patients who have sulfa allergies. Now, what part of the loop of Henle do we say that the loop diuretics work in? Well, in the thick ascending limb. So loop diuretics inhibit the sodium chloride potassium cotransporter. And if you can't actively pump those electrolytes out of the filtrate into the interstitium of the medulla of the kidney won't be so hypertonic, which means that back in the thin descending limb, you won't be able to concentrate the urine. So even though loop diuretics increase the amount of sodium and potassium and chloride in the urine, they also promote a more dilute urine because the urine volume is just so high. And loops also increase calcium excretion. So loops lose calcium. Loops lose calcium, and thiazides retain calcium. I want you to remember that entire phrase. Loops lose calcium, thiazides retain calcium. So if you have a patient with hypercalcemia and you want to lower the serum calcium, you could reach for a loop diuretic. And if you want to retain calcium, you could reach for a thiazide. So when do we use loop diuretics? Well, they're used mainly in patients with serious edema, CHF, pulmonary edema, nephrotic syndrome, cirrhosis, things where you have a lot of fluid that you need to get rid of relatively quickly. You might use a loop diuretic. The loop diuretics are the most potent diuretics that we have. Now, loops are not commonly used for hypertension. They do reduce blood volume, they do reduce the blood pressure some, but it's much more common to treat hypertension with a thiazide diuretic than with a loop diuretic. Then for the side effects of loop diuretics, the most common side effect is probably hypokalemia. Patients taking loop diuretics chronically are going to excrete a lot of potassium, and they can potentially become hypokalemic. We often have to give these patients potassium supplements. And obviously when you're losing a lot of fluid, you can become dehydrated. Loops can precipitate gout because they interfere with uric acid excretion. We already mentioned the possibility of a sulfa allergy, except for which one? What's the loop that's not associated with a sulfa allergy? Ethacrenic acid. It's the only one that's not a sulfa drug. So if you have a patient who needs a loop diuretic but is allergic to sulfa drugs, you could use ethacrenic acid. That's really about the only time we use ethacrenic acid. And it's pretty rare, but loop diuretics may cause ototoxicity and nephrotoxicity, similar to the aminoglycosides and also to vancomycin. So if you give a loop diuretic plus an aminoglycoside, you could really increase the risk of ototoxicity and nephrotoxicity. Making our way through the nephron, we're going to leave the loop of Henle and arrive in the distal convoluted tubule, which is the site of action of the thiazide diuretics. Now, thiazides are probably the second most potent class of diuretics. There are a ton of different thiazides, but the ones that actually get used most often, therefore the ones you're most likely to see on your test, are chlorthalidone, hydrochlorothiazide, which we often abbreviate HCTZ, and metolazone. And hydrochlorothiazide, or HCTZ, is probably the most commonly used one of all of these. Now, thiazides work by inhibiting reabsorption of sodium and chloride in the distal convoluted tubule, so they reduce the diluting capacity of the nephron. This means you're losing a relatively high electrolyte fluid in the urine. And as I mentioned, thiazides retain calcium, so they decrease calcium excretion. And you're going to have less calcium in the urine, and therefore more calcium in the serum. And this can be useful if you have a patient who's at high risk of developing osteoporosis. They have some hypertension as well. You could start a thiazide, which is going to lower the blood pressure. It may also help prevent osteoporosis because it prevents calcium excretion. It may raise the serum calcium slightly. But the main clinical use of thiazides is to treat hypertension, as we mentioned back in the cardiovascular section. Remember, thiazides are one of 4 classes of drugs that are used first line to treat hypertension for most patients. Remember, those 4 classes of drugs were the thiazides, the ACE inhibitors, the ARBs, and the calcium channel blockers. Now, on the other hand, it's much less common to use thiazides for CHF or other edematous diseases. We're usually going to use more potent diuretics for those, like a loop diuretic. Now, you might use thiazides for idiopathic hypercalciuria. So if you have a patient that has normal serum calcium, but who dumps a lot of calcium in the urine, that's going to cause calcium stones. So a thiazide might help prevent this because it's going to prevent some of that calcium from going into the urine. But if you have elevated serum calcium, maybe from hyperparathyroidism, and that's causing you to spill calcium in the urine, then you don't want to use a thiazide in those patients because the thiazide is only to make the hypercalcemia worse. So you don't give a thiazide to a patient with hypercalcemia. But if the patient has idiopathic hypercalciuria, you can give a thiazide to prevent those calcium kidney stones. And thiazides are also used to treat nephrogenic diabetes insipidus. We're going to talk about that in the next video. Then for side effects, thiazides can cause hypokalemia, just like the loop diuretics can. That's very important. They can also cause hyponatremia, hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Remember, we said loops lose calcium, thiazides retain calcium. And thiazides are also sulfa drugs, so you're going to want to avoid these in patients with sulfa allergies. Our last group of diuretics are the potassium-sparing diuretics, which we said work in the collecting tubules primarily. Remember, all potassium-sparing diuretics are not created equal. The common feature is that they all spare potassium. Instead of promoting potassium excretion like the loops and the thiazides do, the potassium-sparing diuretics reduce potassium excretion. They help potassium stick around. So one way to remember which diuretics are potassium-sparing diuretics is the phrase, take a seat. You capitalize the K in take because that's the chemical symbol for potassium, and you're saying take a seat because you want the potassium to stay put. Then the letters SEAT stand for spironolactone, eplerenone, amiloride, and triamterene. But the reason we say they're not all created equal is that spironolactone and eplerenone are aldosterone antagonists. And then amiloride and triamterene work by blocking sodium channels, but they don't antagonize aldosterone. They work a little bit differently. So if you had a patient with hyperaldosteronism, you could treat with spironolactone or eplerenone. Think about it. Aldosterone causes retention of sodium and loss of potassium, so an aldosterone antagonist will counteract this. We sometimes give a potassium-sparing diuretic, especially triamterene, concurrently with a loop diuretic or a thiazide diuretic. So say you have a patient with CHF and you're starting furosemide and the patient starts to get hypokalemic. Well, you might give a potassium-sparing diuretic along with the loop diuretic in order to retain some potassium and prevent that hypokalemia. And then in CHF, remember that the aldosterone antagonists have been shown to reduce morbidity and mortality in these patients with heart failure. So we can use these in low doses in patients with CHF. We said that the patient with CHF needs to be on several different drugs. They need to be on a specific beta blocker, they need to be on an ACE inhibitor or an ARB, and they need to be on one of these aldosterone antagonists. So those are the drugs that have been proven to increase survival and reduce mortality in CHF patients. And then if that patient's having fluid retention, they most likely need to be on a stronger diuretic as well. Now, what about the side effects of the potassium-sparing diuretics? Well, obviously, retention of potassium could lead to hyperkalemia, and that can lead in turn to arrhythmias like VTAC or VFib. You should also know that spironolactone is very structurally similar to sex hormones, and it can antagonize androgen receptors and cause gynecomastia in men. So you remember the mnemonic STACKed for the drugs that cause gynecomastia? Well, the S was for spironolactone. Now, occasionally we use these anti-androgen effects therapeutically. So we might give spironolactone to treat acne or to treat polycystic ovarian syndrome or PCOS. Now, spironolactone also has progesterone agonist activity, and that can cause some menstrual irregularities in women. And it's worth noting that eplerenone is more specific for the mineralocorticoid receptor. It doesn't really bind to the androgen receptors. So you're not going to get anti-androgen effects with eplerenone the way you do with spironolactone. All right, now let's go ahead and do a quick whiteboard review. For this review, we're going to sort all these different diuretics into the correct classes based on where in the nephron they work. We're going to start in the most distal nephron just to switch things up. So out in the collecting duct or the collecting tubule, you have the potassium-sparing diuretics. The mnemonic we had was take a seat. So the S is for spironolactone, the E is for eplerenone, the A is for amiloride, and then the T is triamterene. So those are your potassium-sparing diuretics. Then working back up the nephron, we have the distal convoluted tubule. And what works there? The thiazides. So the three thiazides we talked about were chlorothalidone, hydrochlorothiazide, that one's pretty easy to recognize, and metolazone. Then going back to the thick ascending limb and the ascending loop of Henle, those of course are the loop diuretics. The loop diuretics are bumetanide, ethacrynic acid, furosemide, and torsemide. And then what do we say was special or unique or different about ethacrynic acid? It's the only one of these that's not a sulfa drug. And then we're back to the proximal convoluted tubule. In the proximal convoluted tubule, we have two different types of diuretics that work here. We have the carbonic anhydrase inhibitors, and we have the osmotic diuretics. So which one is which? Well, the carbonic anhydrase inhibitor is acetazolamide, and then the osmotic diuretic is mannitol. Now let's go ahead and circle all the different diuretics that are sulfa drugs. So our sulfa drugs include acetazolamide, 3 of our 4 loop diuretics, and then all of the thiazides are sulfa drugs. So for your reward, we're going to put Dr. Lewis in a little roller coaster, because that's what the nephron always looks like to me. And he's just getting ready to go down this big, crazy hill. And this roller coaster is called the Renal Screamer. Like a nice, scary name. And unfortunately, Dr. Lewis tends to get a little bit motion sick. Before we wrap up, I want to briefly review some of the electrolyte and pH changes associated with these various diuretics. So virtually all diuretics will increase urinary sodium chloride, with the exception of acetazolamide. All of them are going to increase urinary potassium, except for the potassium-sparing diuretics. And you can get hypokalemia as a result of most of these other diuretics. And then for acid-base balance, we discussed how carbonic anhydrase inhibitors will cause some metabolic acidosis. You can also get some acidosis with the potassium-sparing diuretics. But with the loops and the thiazides, as you lose lots of sodium chloride in the urine, you're becoming slightly hypochloremic. And that hypochloremia results in reduced excretion of bicarb. When there's more bicarb in the serum, that's alkalosis. And this is sometimes mistakenly called contraction alkalosis, as in the patient becomes volume contracted from using a lot of diuretics, or they become volume contracted from prolonged vomiting. But the truth is, it's probably hypochloremia that's driving the alkalosis. All right, so that's it for the diuretics. Now it's time for the end of session quiz. So go ahead and answer those, and then we'll go through the answers. All right, first question. What type of diuretic is each of the following drugs? So again, it's not enough to simply recognize these drugs as diuretics. You need to know what kind of diuretics each one is. So triamterene is a potassium-sparing diuretic. Acetazolamide is a carbonic anhydrase inhibitor. Hydrochlorothiazide, it's pretty easy, it's a thiazide diuretic. Bumetanide is a loop diuretic. Spironolactone is a potassium-sparing diuretic, more specifically an aldosterone antagonist. Ethacrynic acid is a loop diuretic, and specifically it's the one that's not a sulfa drug. Mannitol is an osmotic diuretic. Metolazone is a thiazide diuretic. Chlorothalidone is a thiazide diuretic. Furosemide is a loop diuretic. Amiloride is a potassium-sparing diuretic. And torsemide is a loop diuretic. Next, what diuretic or class of diuretic would be most useful in each of the following situations? So for acute pulmonary edema, remember we said that for heart failure, which is where you're classically going to have acute pulmonary edema, we have the mnemonic no lip, and the L in that no lip was for loop diuretics. The next bullet says idiopathic hypercalciuria resulting in calcium stones. This is where you might want to give a thiazide to reduce renal calcium excretion. So again, loops lose calcium, thiazides retain calcium. Glaucoma, we said the two diuretics that are occasionally used to treat glaucoma are acetazolamide and mannitol. Mild to moderate CHF with expanded extracellular volume. So if this is really mild, you might use a thiazide, but classically with heart failure patients, you're going to use a loop diuretic. In conjunction with loops or thiazide diuretics to retain potassium, that would be any of the potassium-sparing diuretics. Edema associated with nephrotic syndrome, usually you're going to reach for a loop diuretic. Increased intracranial pressure, you're going to go for mannitol again, not for its diuretic action, but to act as an osmolar load that's going to draw that fluid out of the brain interstitium. Mild to moderate hypertension, if you're going to use a diuretic to treat hypertension, it's generally going to be a thiazide diuretic. Hypercalcemia, you're going to reach for a loop diuretic to lose the calcium. For altitude sickness, you're going to use acetazolamide. And for hyperaldosteronism, you'd use spironolactone or eplerenone because, again, those directly antagonize the aldosterone receptors. Next, what's the site of action of the thiazides? So they work in the distal convoluted tubule. And the last question, a patient with heart failure exacerbation needs a diuretic but has a sulfa allergy. So what diuretic can you use? Well, again, loop diuretics and thiazide diuretics are both sulfa drugs. So ethacrynic acid is a loop diuretic we talked about with this one that's not a sulfa drug. All right, that's it for Renal 4. I'll see you next time.
It's time for another warm-up review. Let's get going. First one here, which bacterium is an obligate anaerobe, gram-positive, spore-forming rod? So think of Clostridium species. Next, why are aminoglycosides ineffective against gram-positive anaerobes? Well, aminoglycosides are ineffective against gram-positive anaerobes because they are antibiotics that require oxygen to enter into the bacterial wall. Remember that you use O2 and amine O2 glycosides. That's one way to remember that. And that helps you to get to that point. Now, aminoglycosides are commonly given for gram-negative infections, but what do we use for anaerobes? Remember, we use things like metronidazole and clindamycin. Next, damage to which part of the basal ganglia causes hypokinesia? So this is the substantia nigra pars compacta, which can be affected in Parkinson's disease. All right, that's it for the review. Let's get to the video.
In this video, we're going to talk about some electrolyte disorders because the kidneys are integral to maintaining balance of things like sodium and potassium and calcium in the serum and in the interstitial fluid. Now, one of the ways that the kidney maintains homeostasis of these electrolytes is through hormones. We don't often think about it, but the kidney is actually a very important endocrine gland. For example, the JG cells, the juxtaglomerular cells in the kidney, make renin when they're stimulated by one of three things: epinephrine acting on the beta-1 receptors, perceived low blood pressure in the afferent arterioles, or low sodium in the distal tubule as sensed by the macula densa. So again, that ties directly into sodium balance. Then in terms of maintaining calcium balance, the kidneys help to convert vitamin D to its active form. So the skin makes vitamin D with the help of UV light. And then the liver adds a hydroxyl group, so you have 25-hydroxy vitamin D. And then the kidneys have an enzyme called 1-alpha hydroxylase that adds a second hydroxyl group to make 1,25-hydroxy vitamin D. And that's the active form. And that's facilitated by PTH. So if there's a lot of PTH, a parathyroid hormone, around, you'd have more vitamin D around. And the main thing that vitamin D does is increase the intestinal absorption of both calcium and phosphate. When we get to hematology, we'll talk about how the kidneys make a hormone called erythropoietin, which stimulates the bone marrow to make more red blood cells. So with kidney disease and kidney failure, erythropoietin levels are low, and these patients will be commonly very anemic. So we often give shots of erythropoietin to kidney failure patients. And then the kidneys also make prostaglandins, which dilate those afferent arterioles and increase GFR and increase renal plasma flow. This is actually a paracrine function because it's happening locally rather than sending this hormone off to some distant site in the body. And we talked about how NSAIDs can reduce prostaglandin production and therefore reduce GFR. Now, those are the hormones that are produced by the kidney. What about hormones that affect the kidney? Well, I just mentioned how PTH stimulates the kidney to activate vitamin D. PTH also stimulates the kidneys to increase reabsorption of calcium and to decrease reabsorption of phosphates so that serum phosphates go down. Remember, we said PTH is phosphate trashing hormone. We've also talked about the renin-angiotensin-aldosterone system several times already, so that's how hormones affect the kidney. Another hormone we've mentioned before is atrial natriuretic peptide, which is released by the atria of the heart in response to increased atrial volume and increased atrial pressure. So if the heart perceives that the atrial pressure is too high, it can send a hormone signal to the glomerulus to constrict the efferent arterioles and dilate the afferent arterioles. And that's going to increase GFR, and that's going to lead to diuresis. So ANP does the opposite of aldosterone. Instead of retaining fluid and expanding the intravascular volume and raising the blood pressure, ANP causes diuresis and helps to reduce the blood pressure a little bit when the atria become overfull. The kidneys also respond to vasopressin, which is also called antidiuretic hormone, or ADH. And we've seen how ADH permits the collecting tubules to reabsorb water and therefore concentrate the urine. Remember, antidiuretic hormone causes anti-diuresis, which means you're retaining water and you're concentrating the urine. Next, let's talk about two disorders that are both related to ADH. First, we'll talk about the syndrome of inappropriate ADH, or SI-ADH, where you have too much ADH. Then later we'll talk about a deficiency of ADH, which is diabetes insipidus. So SI-ADH means you have too much ADH. So you're reabsorbing too much free water and you're excessively concentrating the urine. So these patients have very concentrated urine and very dilute serum. They have low serum osmolality and low serum sodium. That's why we're talking about it here. SI-ADH is a very common cause of low sodium. So what causes SI-ADH? Where's all this ADH coming from? Well, ectopic ADH production from a small cell lung cancer can do it. That's a paraneoplastic syndrome. Really, any pulmonary pathology can cause SI-ADH. COPD, pneumonia, anything in the lung. Then also anything in the head can cause SI-ADH. So head trauma, stroke, CNS infections, anything going on in the head. Sometimes drugs can cause it, especially the immunosuppressant cyclophosphamide. But you're going to see lots of people with low sodium and SI-ADH. You're not going to see lots of people on cyclophosphamide. And then plenty of times you won't identify a specific cause. It's just idiopathic SI-ADH. Now, if you correct hyponatremia too quickly, you might cause lysis of the myelin in the pons, which is called central pontine myelinolysis. That's one of the causes of the locked-in syndrome, where the patient's conscious, but they can't move anything and they can't communicate. So it's a pretty devastating complication. Then the opposite of too much ADH would be too little ADH, which is the problem in diabetes insipidus, or DI. So what does this look like clinically? Well, ADH helps you reabsorb water in the collecting tubules so that you concentrate the urine and you produce less urine. So without ADH, you can't concentrate the urine. You're going to have increased urine volume and the urine is going to be very dilute. And this is going to cause a highly concentrated serum as a consequence. So serum osmolarity is high, but the urine-specific gravity is low. And there are two flavors of DI. There's central DI, where the hypothalamus isn't producing ADH normally. If the hypothalamus isn't making any ADH, we call that complete central DI. But more commonly, the hypothalamus makes just a little bit of ADH, but just not enough. So we call that partial central DI. So central DI is one big category of DI, and the other category is nephrogenic DI, where the kidneys have become unresponsive to ADH. So in nephrogenic DI, the hypothalamus is making ADH normally, but the kidneys just can't respond to it. So what would make the kidneys stop responding to ADH? Lithium is one thing. We've seen this diagram elsewhere, and it keeps coming back to haunt us. This is the mechanism by which lithium causes diabetes insipidus, and it's worth knowing. Remember, ADH causes the principal cell in the collecting tubule to insert these aquaporin water channels into the luminal side of the cell so that water will be reabsorbed. But lithium interferes with that process. So lithium is one drug that can cause nephrogenic DI. Another drug is dimeclocycline, which is a cousin of tetracycline. Dimeclocycline also interferes with the action of ADH, so sometimes we use it off-label to treat chronic SI-ADH because you're blocking the action of ADH. I don't know if I've ever seen dimeclocycline used as an antibiotic, but I have seen it used for SI-ADH. But because it prevents the kidneys from responding to ADH, it can cause nephrogenic DI. Hypercalcemia can potentially cause some nephrogenic DI as well. And there's also a hereditary form where you simply have a mutation in the gene for the ADH receptor. For step one, you need to be able to interpret lab results and recognize what type of diabetes insipidus the patient has. So say you have a patient who presents with excessive thirst and polyuria. Well, the first thing you'll probably think about is diabetes mellitus, which you can easily rule out by checking the urine for glucose and checking the serum glucose. But say that's normal. The next thing you would test is urine and serum osmolality. And what do you expect those labs to show in diabetes insipidus? Well, the patient is losing free water in the urine, so the urine osmolality is low and the serum osmolality is high. Then the next test you do to confirm the diagnosis is called a water deprivation test. So this is where you restrict the patient from drinking water and then you recheck the urine osmolality. Now in a healthy patient, the patient is going to get slightly dehydrated when you water restrict them, and they'll secrete ADH and start concentrating the urine. So if the urine osmolality rises after water deprivation, that's a normal result. But a patient with diabetes insipidus can't concentrate the urine, so the urine osmolality will stay low. That tells you this patient definitely has diabetes insipidus. Then how do you distinguish between central diabetes insipidus and nephrogenic diabetes insipidus? Well, you need to do a test called a desmopressin challenge, where you give the patient an ADH analog called desmopressin. Now, if you give desmopressin to a patient with central diabetes insipidus, the urine osmolality will finally rise because you've corrected the patient's ADH deficiency. And technically, that urine osmolality has to rise by at least 50% to be considered positive for central DI. But if you give desmopressin to a patient with nephrogenic DI, that patient already has plenty of ADH circulating, but the kidneys can't respond to it, right? So if you give desmopressin to a patient with nephrogenic DI, the urine osmolality will not change, or it might rise very slightly, but less than 50%. So how do we treat diabetes insipidus? Well, if it's central DI, then the treatment would be intranasal desmopressin. You're just replacing the hormone that's deficient. For nephrogenic diabetes insipidus, it's a little trickier. First-line treatment is hydrochlorothiazide, or HCTZ, which doesn't automatically make sense. They've got DI, so they're peeing too much, and now you're giving a diuretic to make them pee more? Well, the deal is that the hydrochlorothiazide causes the patient to become a little bit dehydrated. And that means that back in the proximal tubule, the workhorse, where most of the reabsorption takes place, the kidney is going to reabsorb more water, so that by the time the urine gets to the collecting tubule, it's already a little bit more concentrated. Remember, the proximal tubule and the loop of Henle tend to concentrate the urine, and the distal tubule dilutes it. Then the collecting tubule is supposed to concentrate it again. So HCTZ is basically preventing the distal tubule from diluting the urine. So HCTZ is first-line treatment for nephrogenic DI. Second line would be indomethacin, which can also be used in addition to HCTZ. Indomethacin will inhibit prostaglandin synthesis and reduce renal blood flow, and that's going to decrease urine output somewhat. And then if you're treating lithium-induced nephrogenic diabetes insipidus, the potassium-sparing diuretic amiloride is also particularly helpful. Amiloride blocks the sodium channels that lithium uses to enter the principal cell. So sometimes when you have a bipolar patient who really needs lithium, but he's getting diabetes insipidus from it, you can add some amiloride and that'll allow the patient to stay on lithium. I mentioned that SIADH is a common cause of low serum sodium, or hyponatremia. So let's briefly talk about some of the important signs and symptoms associated with electrolyte disorders. This is very, very testable. So they might give you a clinical scenario and show you an EKG and expect you to recognize if there's hyperkalemia, for example. So let's look at some high-yield electrolyte disorders. First of all, hyponatremia, or low sodium, can cause confusion and altered mental status, especially in the elderly. It can also lead to seizures, it can lead to stupor and coma. Now, that's pretty nonspecific, but just be aware that when the electrolytes get out of whack, it messes with the resting potential of neurons, and that causes CNS problems. Another disorder that classically will cause some confusion is hypercalcemia. Now, in endocrine, we have a whole video on calcium metabolism. Dr. Cox is going to discuss all the clinical manifestations of hypercalcemia, which include stones, bones, abdominal groans, and psychiatric overtones. So those psychiatric overtones can include pretty serious confusion and delirium. These patients can get crazy weird. Then with low calcium, or hypocalcemia, you need to remember tetany, which we test for with Trousseau sign. Remember T for Trousseau and T for tighten the cuff, tighten the blood pressure cuff on the arm, and causes carpopedal spasm. And you can also test for Schwastek sign, so CH for cheek and CH for Schwastek. You're tapping on the cheek, and tapping on the facial nerve and getting facial nerve spasm. And then hypomagnesemia, or low magnesium, will also cause tetany. But then hypermagnesemia, or high magnesium, will depress the reflexes. So if you give IV magnesium to a pregnant mom who's in preterm labor, You're giving it to try to suppress muscle contractions and stop the labor. But if you give too much, you'll cause hyporeflexia. So if we're giving a magnesium drip, we're going to do serial neuro exams, and if the DTRs go from 2+ down to 1+, you know you need to stop the magnesium for a little while. You're getting a little too much magnesium. Then going back to hypomagnesemia or low magnesium, that can also cause EKG abnormalities and arrhythmias. So low magnesium causes a wide QRS complex and could cause torsade de pointe, which is a form of VTAC, where the VTAC has variable amplitude. So it gets bigger and then it gets smaller, bigger and smaller. It's pretty easy to recognize. And speaking of VTAC, I want you to remember that low magnesium and low potassium tend to go together. So hypokalemia can prolong the QT interval and lead to VTAC and torsades just like low magnesium can. And actually, hyperkalemia can also lead to VTAC. Potassium's kind of like Goldilocks. It's got to be just right or you can get into trouble quick, whether it's too low or too high. But the classic EKG findings I want you to remember with hyper and hypokalemia are that the T waves tend to mirror the potassium levels. So if the potassium's high, T waves are going to be high. They're going to be tall and peaked. We say the T waves look sharp, like you wouldn't want to sit on them. They're just sharp and pointy. But if the potassium is low, then the T waves are somewhat flattened. And if the potassium is really, really low, you might see a prominent U wave, which is a wave that comes after the T wave. Now, while we're talking about potassium, let's look at number 4 in your study guide and talk about potassium shifts. Like I said, serum potassium needs to be just right. So serum is relatively low in potassium, but the intracellular fluid is relatively high in potassium. So what kinds of things shift potassium outside of the cells, and that's going to cause hyperkalemia and potentially affect the heart? Well, low insulin can do it. So diabetic patients might be more prone to have hyperkalemia, especially if they're in DKA because they have low insulin. Beta blockers can shift potassium out of cells. Acidosis can also do it. Remember, with acidosis, your cells are trying to correct the acidosis by moving all those excess hydrogen ions out of the blood. They're trying to raise the pH and get rid of that hydrogen ion in the blood. So the mechanism they use to accomplish this is to exchange hydrogen ions for potassium ions. And that results in pumping too much potassium out of the cells into the blood. So acidosis can lead to hyperkalemia. Then digoxin can shift potassium out of cells. And then cellular lysis can do it as well. If your cells die and they rupture, they're going to leak all that potassium into the interstitium and into the blood. Then what kinds of things shift potassium into the cells? Well, it's just the opposite. Insulin, beta agonists, alkalosis, and cell creation or cell proliferation, like with cancer. Now, why is this clinically relevant? Well, let's say on your exam they give you this EKG and they ask you what intervention would correct this finding. Well, what does this EKG show? Tall, peaked T waves. And what electrolyte abnormality does that suggest? Hyperkalemia. That is what you said, right? Speak up next time. So if you see tall, peaked T waves, you're going to think about hyperkalemia. And then you need to know how to treat it before the patient goes into VTAC and cardiac arrest. So you need to figure out a way to shift potassium back into the cells as quickly as possible. So one thing you could do to help correct this hyperkalemia acutely is to give them a beta agonist like albuterol. You give them some nebulized albuterol and that's going to start to shift potassium into the cells. Alkalosis would help too, so you could give IV bicarb as well. You can also give some insulin, especially IV insulin. The only caveat here is that insulin is going to lower the blood sugar rapidly, so we give IV dextrose and then give the insulin to make sure that the glucose doesn't bottom out. So 3 emergency treatments that are helpful to correct hyperkalemia are a beta agonist like albuterol, IV bicarbonate, and IV insulin plus dextrose or D50. But you also need to know that the first treatment for serious hyperkalemia with EKG changes is to give IV calcium to stabilize the myocardium and to prevent arrhythmias like VTAC. Now, calcium will not shift potassium into the cells, so it won't correct the hyperkalemia, but it does prevent arrhythmias. So the first treatment for severe hyperkalemia is to give IV calcium. Now, that brings us to the end of session quiz. So pause the video, work through those questions, and then we'll go through the answers together. First question, which electrolyte disturbance fits each of the following presentations? Correcting too rapidly may result in central pontine myelinolysis, is hyponatremia. Peaked T waves is hyperkalemia. Tetany would be seen with hypocalcemia and also hypomagnesemia. Arrhythmias could be hyperkalemia, could be hypokalemia, or could be hypomagnesemia. Decreased deep tendon reflexes are seen with hypermagnesemia. And then flattened T waves with U waves on EKG would be hypokalemia. Next, what are the diagnostic features of diabetes insipidus? Well, the patient's going to have polyuria, and the urine is going to be dilute, so you have low specific gravity and low urine osmolality. Then on water deprivation test, if the urine osmolarity does not rise with water deprivation, that's diagnostic for diabetes insipidus. Then you're going to distinguish between central and nephrogenic DI by giving desmopressin. So if you give desmopressin and the urine osmolarity rises, this points towards central DI. But if the urine osmolarity does not rise, this points toward nephrogenic DI. Next, what factors or substances cause hyperkalemia? So we talked about things that shift potassium out of cells: acidosis, insulin deficiency, beta-adrenergic antagonists, digoxin, and cellular lysis. But I also want to throw in potassium-sparing diuretics and ACE inhibitors. Now, those don't cause potassium to shift out of the cells, but they can cause hyperkalemia. And then the next question, what factors or substances cause hypokalemia? Again, the things that shift potassium into cells are insulin, beta-agonists, alkalosis, and potentially cell proliferation. Then we can add loop diuretics and thiazides as potential causes of hypokalemia because they cause the patient to dump a lot of potassium into the urine. So that's it for the end of session quiz. And now we have 3 rapid-fire facts. So the treatment for central DI, again, it's desmopressin. The treatment for nephrogenic DI is hydrochlorothiazide or HCTZ, indomethacin, and possibly amiloride. And the treatment for lithium-induced nephrogenic DI is amiloride. All right, see you next time.
It's time for another warm-up review. Let's get going. What are the toxic side effects of tricyclic antidepressant use? So the mnemonic here is tri-Cs. So remember the C's: cardiotoxicity, CNS toxicity, something like coma or seizures, and then anticholinergic symptoms. And then you can also see hyperpyrexia and respiratory depression. Now, what are some of the characteristics of polymyositis that distinguish it from polymyalgia rheumatica? Well, in polymyositis, you have muscle weakness as well as elevated CK, ADAlase, ANA, anti-Jo1, and then in polymyalgia rheumatica, there is joint pain but no muscle pain or weakness. And since there is no muscle inflammation, CK and ADAlase will be normal. Next, MPTP exposure causes depletion of which neurotransmitter? So the neurotransmitter is dopamine because MPTP is converted to MPP, which destroys those dopaminergic neurons in the substantia nigra. All right, that's it for the review. Let's get to that video.
Welcome to our video on acid-base disorders. Now, back in the 60s and the 70s,
acid meant LSD.
And in the 80s, everybody was worried about acid rain. And in the 90s, we had acid-wash jeans. But now that I'm all grown up, when I hear acid, I think mud piles. Let's start by talking about the 4 basic types of acid-base disorders, starting with acidosis. Respiratory acidosis takes place when you're hypoventilating and you're retaining CO2. Now, lots of things can cause hypoventilation, either acutely or chronically. Airway obstruction and air trapping, any type of lung disease, especially interstitial lung disease like pulmonary fibrosis, weak respiratory muscles, especially weakness of the diaphragm, and drugs like opioids, which suppress the respiratory drive. Metabolic acidosis occurs either because you're adding acid to the blood or because you're losing excessive bicarb. So metabolic acidosis can be further categorized based on whether there's high anion gap or normal anion gap. When you add acids to the blood, that causes a high anion gap acidosis. In case you've forgotten, anion gap is calculated by taking the serum sodium and subtracting the serum chloride and bicarb. Serum potassium is so low relative to sodium that we just kind of ignore it. So it's sodium minus chloride minus bicarb, and that's the anion gap. And the anion gap is normally around 10 to 12. If you add acid to the blood, such as lactic acid, the lactic acid will be buffered by bicarb, and the anion lactate will be present in the blood. So the serum bicarb is lower, and the sodium and chloride are unchanged, and as a result, the anion gap is higher. So again, adding acids to the blood leads to a high anion gap acidosis. And the mnemonic for the causes of high anion gap metabolic acidosis is mud piles. It's definitely important to know. The M in mud piles is for methanol. The U is for uremia or renal failure. The D is for diabetic ketoacidosis. P is for propylene glycol. Then I is for two things, iron tablets and also isoniazid. The L is for lactic acid. Now, when are you most likely to see lactic acidosis? In a patient who's in shock or who's coding and they're not perfusing their tissues very well, so lactic acid's building up. Then the E in mud piles is for ethylene glycol, which is found in antifreeze. There are lots of organic acids on this list that people might drink for one bad reason or another. Methanol, propylene glycol, ethylene glycol. And then the S is for salicylates like aspirin. And technically speaking, the reason that salicylates cause a high anion gap metabolic acidosis is that they induce lactic acidosis. But salicylates are going to stay on this list because people will come in after trying to commit suicide by overdosing on aspirin, so you may actually see this. Then a normal anion gap acidosis is where you aren't adding acids, but instead you're losing bicarb. And this can be from a bunch of less dramatic things like diarrhea, renal tubular acidosis, spironolactone, or acetazolamide. We're going to talk about RTA, or renal tubular acidosis, in just a second. Okay, so what kinds of things cause alkalosis? Well, respiratory alkalosis is when you're hyperventilating and you're blowing off CO2. Maybe there's a psychogenic cause like an anxiety attack or a panic attack. Maybe you're at a high altitude and you're starving for oxygen, so you increase ventilatory rate. Or if you have some acute hypoxemia like a PE, a pulmonary embolism, and that makes you hyperventilate, so you're blowing off a bunch of CO2. And also aspirin toxicity can lead to hyperventilation. Now hold on. Didn't I just say that salicylates like aspirin cause metabolic acidosis? Why yes, I did. The deal is that early on, if you take a bottle of aspirin, aspirin will directly stimulate the respiratory center in the brain and cause hyperventilation. Then later, you might see some metabolic acidosis, but that happens much later. Now, what about metabolic alkalosis? Typically, this occurs when you're losing hydrogen ion in some way. Excessive vomiting can do this. Diuretics can do this. We talked about those on the video on diuretics, where you can lose chloride and then the hypochloremia results in alkalosis. And hyperaldosteronism can do it as well. So with hyperaldosteronism, you're going to see this triad of hypokalemia, hypertension, and metabolic alkalosis. Now let's talk about renal tubular acidosis. So there are three types of RTA to know about, and all three of these result in a non-anion gap metabolic acidosis. So the first one is type 1 RTA, or distal RTA. So as the name suggests, this is a defect in the distal nephron. So we're talking about the collecting tubule. Remember when we talked about the two types of intercalated cells you have in the collecting tubule. You have alpha cells, which secrete hydrogen, and then you have beta cells, which secrete bicarb. Well, in type 1 RTA, the alpha intercalated cells in the collecting tubule are unable to secrete hydrogen ions, which means that the hydrogen ions are going to stay in the body and the patient becomes acidotic. So the main thing to know with this one is that the urine pH is greater than 5.5. If you're not able to secrete hydrogen ions into the urine is going to become more alkaline and the urine pH is going to be high. So that's a big clue. Then the other clue is that these patients have hypokalemia. So if you have a metabolic acidosis where the urine pH is greater than 5.5 and it's associated with some hypokalemia, you may be dealing with type 1 RTA. Then the other important type of RTA to know about is type 4 RTA, which is often due to hypoaldosteronism. So low aldosterone causes type 4 RTA. And think about it. If aldosterone's low, you're not putting potassium into the urine. So these patients have hyperkalemia. And that hyperkalemia prevents the proximal convoluted tubule from generating ammonium, which means the urine pH is going to be low, less than 5.5. So urine is usually acidic. So in type 4 RTA, urine pH is appropriately low. But with type 1 RTA, urine pH is higher, more alkaline. That's kind of unusual. And then type 2 RTA is a proximal tubule defect of bicarb reabsorption. And it's associated with hypokalemia and hypophosphatemia. And again, the urine pH is appropriately low. Now, we have a mnemonic to help keep all these straight. Type 1 RTA has to do with impaired hydrogen excretion. And the symbol for hydrogen is H, which is one letter. So type 1 RTA, hydrogen excretion is impaired. Then type 4 RTA has to do with impaired ammonium excretion. And the chemical formula for ammonium is NH4, type 4. And type 4 is also associated with low aldosterone. And lots of people abbreviate aldosterone as aldo. And aldo has 4 letters, ALDO, 4 letters, type 4 RTA from hypoaldosteronism. And then type 2 RTA has to do with impaired bicarb reabsorption. And the bi in bicarb makes you think of 2, so type 2 RTA. Let's talk about how you would determine what type of acid-base disorder a patient has based on an arterial blood gas. With an ABG, you're going to get several values: serum pH, serum bicarb, partial pressure of oxygen, and partial pressure of CO2. So, how do you use these numbers to determine whether you're dealing with a metabolic acidosis or respiratory alkalosis or whatever? Well, for starters, there's our old friend, the Henderson-Hasselbalch equation. Just hearing the words Henderson-Hasselbalch makes my palms sweaty. But before you start to panic, you do not need to memorize this equation for step 1. Right? All I want you to remember about the Henderson-Hasselbalch equation is that pH is related to bicarb over PCO2. You don't really need to memorize the entire thing. Just know this one component of it. pH is related to bicarb over PCO2. So what happens when the patient's bicarb level rises? Think about it. Raising the bicarb is a metabolic phenomenon, right? Not respiratory, metabolic. We assume that bicarb is primarily under the control of the kidneys. So how does raising the bicarb affect the pH? It's going to raise the pH. You can also reason it out from this modified Henderson-Hasselbalch equation. pH is related to bicarb over PCO2. Or you just know that bicarb is a base. So if you have more bicarb in the blood's going to be more alkaline. The pH is going to be higher. So raising bicarb will raise the pH. So this would be a metabolic alkalosis. But what if instead of high bicarb, your patient had high CO2? So CO2 is regulated not by the kidneys, but by the respiratory system. You either hyperventilate and blow off CO2, or you hypoventilate and retain CO2. So if you hypoventilate, you start retaining CO2, CO2 in the blood is going to rise. And that means that pH will decrease. Again, since pH is related to bicarb over PCO2, when PCO2 rises, the pH decreases. So this would be a respiratory acidosis. So if you look at the ABG and you figure out whether the CO2 or bicarb are higher or lower than normal, you can easily determine what disorder you're dealing with. If you have a high pH, that means there's an alkalosis. If the bicarb is high, you know that the bicarb caused that high pH. That would be a metabolic alkalosis. If you have a low PCO2, you know that the low PCO2 is what caused the high pH. So that would be a respiratory alkalosis. Now, we've mentioned this before, but if you have a primary alkalosis, your body's going to try to correct that or compensate for that. For example, if you're at high altitude, oxygen tension is low, so you start hyperventilating, trying to oxygenate. That's going to lead to a primary respiratory alkalosis because you're blowing off CO2. So your body's going to try to compensate for that alkalosis by excreting bicarb in the urine. That's compensation. Or if you had a patient with metabolic acidosis from DKA, they're going to be hyperventilating to blow off CO2 and try to raise the pH. That's why DKA patients have Kussmaul breathing. They're trying to compensate. But here's the big clue. A compensatory mechanism should never bring the pH all the way back into the normal range. If you start looking at the ABG and you notice that the PCO2 is out of whack and the bicarb is out of whack, but the pH is normal, that's not simply a case of really good compensation. Compensation should never bring the pH all the way back to normal. If the pH is normal, but the PCO2 and the bicarb are both out of whack, you're probably dealing with a mixed disorder where you have both a primary metabolic acidosis and a primary respiratory alkalosis or whatever. Now, clinically, we use something called Winter's formula to estimate what the PCO2 should be in cases of metabolic acidosis based on the expected respiratory compensation. And if the actual PCO2 is way off from what you expect using Winter's formula, then you know there must be a mixed disorder instead of just compensation. But again, just like I said you don't need to memorize the entire Henderson-Hasselbalch equation, I don't know that Winter's formula is terribly high yield for step 1. I don't think you should bother memorizing it for this test. Now, it is high yield for step 2. It's very useful in the ICU when you're managing these patients, but for step 1, I don't think you need to know it. So, confused yet? I know this stuff is difficult to conceptualize. The best way to master these acid-base problems is with some practice. So take a look at number 4 and number 5 in your study guide. Number 4 is the normal reference values, and then number 5 is a big table of practice problems we're going to work through together. So on number 4, pH is 7.35 to 7.45. For PCO2, you just remove the 7, so the normal PCO2 is 35 to 45. Normal PO2 should be about double the PCO2. So normal PO2 is greater than 90. Then the normal bicarb is about half of the PCO2. I usually remember 22 to 24 for bicarb. So those are your normal gas values. Now let's look at number 5. For each of these ABGs we have listed, I want you to be able to determine what the acid-base disorder is. So the first one, the pH is 7.4, and that's normal. Bicarb is 23, and that's normal. And then the PCO2 is 40, which is also normal. So what type of acid-base disorder is this? Well, this is normal. There's no disorder here. The next one, pH is 7.5. So is 7.5 pH high or is it low? It's high, right? So you're dealing with an alkalosis. You know that right off the bat. Now, which of the other two variables is causing the alkalosis? Is it CO2 or is it bicarb? Well, the bicarb is 35, which is high. So does high bicarb cause alkalosis? Yes. And we said that bicarb is controlled by the kidneys, not by the lungs. So this is a metabolic alkalosis rather than a respiratory alkalosis. But we haven't yet determined what's going on with the PCO2 or the respiratory component. So let's see what's going on there. Here you have a PCO2 of 42, and that's in the normal range. So you know this is a pure metabolic alkalosis without any compensation. Now let's look at the next one. pH is 7.33, which is low. So this is an acidosis. So what's causing the acidosis? Well, the bicarb is 13, and that's also low. So here you have a metabolic acidosis. But what's going on with the PCO2? PCO2 is low, and that should be raising the pH. But here the pH is actually low. So did this low CO2 raise the pH back into the normal range? No. So this is a classic example of metabolic acidosis with some respiratory compensation. Let's do one more of these together, and then I'm going to let you try the rest of them on your own. So the next one says pH of 7.42, and again that's normal, but bicarb of 32 is high. Now high bicarb would suggest that there's a metabolic alkalosis, and the PCO2 is 64, which is pretty high, and that should lower the pH. So is this a case of compensation? Well, again, the pH here is normal, and we said that compensation will not completely correct the pH. So this must be a mixed disorder because both the PCO2 and the bicarb are messed up, but the pH is normal. So this is a combined metabolic alkalosis and respiratory acidosis. They're completely independent of one another. They just happen to be canceling each other out so that the pH ends up in the normal range. So that's basically how you do these. Now I want you to pause the video and try to complete the rest of this table as best you can, then I'll go through them with you. Now don't spend more than 3 or 4 minutes on it, maybe 5 minutes. You can always come back and work on these later. Don't spend too much time. Just go through these as quickly as you can and then restart the video. All right, let's go through these. We left off at pH of 7.2, bicarb 18, PCO2 is 40. So this is metabolic acidosis without compensation. The next one, pH 7.2, bicarb 24, PCO2 54. This is a respiratory acidosis without compensation. The next one with a pH of 7.52 is respiratory alkalosis without compensation. The next one, pH of 7.66, is a combined metabolic and respiratory alkalosis. The next one, pH 7.47, is a respiratory alkalosis with metabolic compensation. The next one, pH 7.46, is a metabolic alkalosis with respiratory compensation. The next one, pH 7.39, is a mixed metabolic acidosis and respiratory alkalosis. So again, it's a mixed disorder rather than metabolic acidosis with respiratory compensation because the pH is in the normal range. Again, compensation shouldn't be able to get the pH back to the normal range. The next one, pH 7.34, is a respiratory acidosis with metabolic compensation. Then the last one, pH 7.10, is a combined metabolic and respiratory acidosis. I hope that was a useful review and you feel a little more comfortable with these kind of problems. Now it's time for the end of session quiz. So pause the video and work through those on your own, then we'll go through the answers together. All right, first question. What are the causes of acidosis with elevated anion gap or high anion gap acidosis? We're talking about metabolic acidosis here. And our mnemonic is mud piles. So you have methanol, uremia, DKA, propylene glycol. I is for iron tablets and also isoniazid. L is for lactic acidosis. Then you have ethylene glycol, and the S is for salicylates. Next, for each set of ABG values, determine the acid-base disorder. So the first one, pH 7.24, bicarb 24, PCO2 53, is a pure respiratory acidosis. The next one, pH 7.58, is a combined metabolic alkalosis and respiratory alkalosis. The next one with pH of 7.23 is a pure metabolic acidosis. And the last one, pH of 7.33, is a respiratory acidosis with metabolic compensation. Last question. A patient with a history of kidney stones presents with hypokalemia and metabolic acidosis. The anion gap is normal. Urine pH is 5.7. What is the underlying defect? Well, this is a patient with renal tubular acidosis, right? But you have to know which type of RTA in order to figure out the defect. Hypokalemia could be associated with either type 1 RTA or type 2 RTA, but only type 1 RTA has the higher urine pH, greater than 5.5. So this is type 1 RTA. Another hint could be that the only type of RTA associated with kidney stones is type 1, and the word stone contains ONE, 1. So what's the defect in type 1 RTA? It's type 1, one letter, hydrogen. The defect is impaired secretion of hydrogen ions by the alpha intercalated cells in the collecting tubule.
That's it for now. See you next time.
These two guys don't get along, but when it comes to education, they are never wrong. Yeah, if you pay attention, you might get an A. They don't like each other, but that's okay, 'cause they are bosom buddies.
Hi, I'm Dr. Lewis.
And I'm Dr. McInnes. Today, I want to talk about the Henderson-Hasselbalch equation.
The what equation? Like Florence Henderson and David Hasselhoff? Just imagine what might happen if they somehow combine forces.
No, you idiot. The Henderson-Hasselbalch equation describes the relationship between pH, bicarb, and PCO2.
Where did that come from?
When serum bicarb is high, the pH is high, indicating alkalosis. And when PCO2 is high, the pH will be low, indicating acidosis.
And the high PCO2 tells you it's a respiratory acidosis.
Exactly.
One question.
What's that?
Do you think I'd look good with a Greg Brady perm?
I give up. I can't work with this idiot anymore. Lewis, Lewis, Lewis!
It's time for another warm-up. Let's get going. Which nerve runs with each of the following arteries? So first we have the anterior interosseous artery. That's going to go along with the anterior interosseous nerve. Next we have the posterior interosseous artery. That's going to go along with the deep branch of the radial nerve. Next we have the posterior circumflex artery. That's going to run with the axillary nerve. Next we have the suprascapular artery. That's going to run with the suprascapular nerve. Next, thoracodorsal artery runs with the thoracodorsal nerve. Deep brachial artery runs with the radial nerve. Dorsal scapular artery, that's going to go with the dorsal scapular nerve. Lateral thoracic artery is going to go on with the long thoracic nerve. The ulnar artery is going to go with the ulnar nerve. And the brachial artery is going to run with the median nerve. Next, what CSF changes are seen in Guillain-Barré syndrome? So there will be normal cell count with an increase in protein in the CSF. So this has actually a name. It's called the albinocytologic dissociation. So you might need to look for that terminology used to describe the CSF findings in Guillain-Barré. Next, what conditions are associated with a rash that involves the palms and the soles? So you can use the mnemonic, we drive Kawasaki cars with our hands and feet to remember the conditions associated with a rash on the palms and soles. So Kawasaki is for Kawasaki disease, and then CARS, C-A-R-S, stands for Coxsackie-A, Rocky Mountain spotted fever, secondary syphilis. And then Neisseria meningitidis could also be included on this list, as a meningococcemia can certainly cause a pulmonary rash, but it is less common than these other Kawasaki-CARS infections. All right, that's it for the warm-up. Let's get to that lecture.
In this video and the next one, we're going to talk about some glomerular diseases that cause glomerulonephritis and nephrosis. Now, being able to recognize these nephritic and nephrotic syndromes is definitely a 4 or 5 star topic. And this is one of those topics that a lot of students tend to automatically tune out and say, this is too hard, it's too confusing, I'm not even going to bother with this. Or they hear the word glomerulonephritis and they have a little panic attack. So I know it's confusing, and I know there are a bunch of diseases and they all have similar sounding names, and there's a lot of overlap between the names, but I don't want you to panic or freak out or give up hope. This is really pretty manageable stuff if you know what to focus on. So let's start with some basic terminology. The first thing to recognize is that nephritis and nephrosis, or nephritic syndromes and nephrotic syndromes, are descriptions of the clinical presentation. They don't necessarily tell you anything about what's causing that clinical picture. The big difference between a nephritic syndrome and a nephrotic syndrome is how much protein is found in the urine. Now, we're going to get into more detail on that later, but for right now, when you hear nephrosis or nephrotic, I want you to think big-time proteinuria. Nephrosis means there's more than 3.5 grams of protein in the urine per day. That's a number worth knowing. Know that cutoff. Proteinuria of more than 3.5 grams per day is nephrosis. Informally, we might call that heavy proteinuria. So anything above 3.5 grams per day is heavy proteinuria. Anything below 3.5 grams per day is called light proteinuria. Now, patients with nephritis will often have some proteinuria, but it's usually less than that 3.5 gram cutoff. There are some types of glomerulonephritis that present with more than 3.5 grams per day. We might say they have nephrotic range proteinuria, but we could still call it nephritis. There are some other features that distinguish nephrosis from nephritis. We're going to cover those in the video on nephrosis. But in general, just remember that greater than 3.5 grams of protein per day is nephrotic. Less than 3.5 grams of proteinuria is nephritic. Now, there are also a handful of terms that we use to further characterize these glomerular diseases based not on the clinical presentation, but based on what we see under the microscope, on biopsy. We're going to look at some microscope slides in a bit because that's really important for step one. But for the vast majority of patients who have kidney disease, they don't actually get kidney biopsies. In practice, it's a lot more common to focus on the clinical presentation. But when we look at the kidney biopsy, we see that less than half of the glomeruli are affected, we call that focal disease. And if more than half the glomeruli are affected, we call it diffuse. So that's why some diseases are called focal segmental glomerulosclerosis and others are called diffuse proliferative glomerulonephritis, just describing what we see on the biopsy. And even that's sort of a rough estimate. It's not like you have to count them all up exactly. But if most of the glomeruli are affected, that's diffuse. If it's only affecting the glomeruli here and there, it's focal. When you look at the biopsy and you see that the basement membrane is thickened, that's called membranous, like membranous nephropathy. And if you have proliferation of cells, that's called a proliferative disease. So diffuse proliferative glomerulonephritis means that the glomeruli are hypercellular, you have proliferation, and that more than half the glomeruli are affected. That's why it's diffuse. And then membranoproliferative glomerulonephritis means that there's both thickening of the basement membrane and proliferation of cells. It's membranoproliferative. You may also hear these diseases referred to as being primary or secondary glomerular diseases. That just tells you whether this is a purely kidney disease, which is primary, or something that's more generalized and more systemic. For instance, patients with lupus and lupus nephritis are said to have a secondary renal disease because the primary problem is lupus. But ultimately, the patterns we see on biopsy can often be attributed to a bunch of different primary disorders. For example, MPGN, or that membranoproliferative glomerulonephritis, can be due to hepatitis B, hepatitis C, lupus, rheumatoid arthritis, monoclonal gammopathies, and so on. So the pattern you see on biopsy isn't necessarily a diagnosis in and of itself. So let's dive in and look at some details about these different diseases, starting with the nephritic syndromes. So itis means inflammation, so glomerulonephritis means inflammation of the glomeruli. Interstitial nephritis is covered in another video, and that's inflammation of the interstitial tissue. Pyelonephritis means inflammation and infection of the renal pelvis and the renal parenchyma. But glomerulonephritis means there's inflammation of the glomeruli. Now, with glomerulonephritis, we already said there might be some light proteinuria, but the big thing clinically that I want you to think about is hematuria. Not necessarily, frankly, bloody urine, although it's possible. Maybe just some reddish urine, maybe brownish urine. And you're going to see red cells when you examine the urine microscopically. And with that, you'll often see red blood cell casts in the urine. If you have inflammation of the glomeruli, there's likely to be blood in the urine and then red cell casts. You'll often see a decline in renal function with nephritis. You'll see azotemia. So azotemia means that the serum BUN and creatinine are elevated. And then when the kidneys aren't working, you'll often see some hypertension because of salt and water retention and expanded intravascular volume. And there may be decreased urine volume, which we call oliguria. And obviously some of these diseases can progress to full-blown renal failure. And that may even cause anuria when the patient doesn't make any urine. So the first type of nephritis I want to discuss is post-streptococcal glomerulonephritis, which is definitely one of the higher yield ones. Now, as you might guess, this is a sequela of streptococcal infection, specific strains of group A strep. You're going to see this in a patient who had strep throat or a group A strep skin infection like impetigo 1 to 3 weeks prior to presenting with glomerulonephritis. So this is a type 3 hypersensitivity reaction where circulating antibodies bind to certain streptococcal antigens and they form immune complexes, and those immune complexes get deposited in the glomerulus. But it's worth mentioning that because this is an immune complex mediated disease, treating strep throat with antibiotics does not prevent post-strep glomerulonephritis. Antibiotics do prevent acute rheumatic fever and they prevent rheumatic heart disease, but they do not prevent post-strep glomerulonephritis. Now, post-strep glomerulonephritis is more common in children. So think about it. Who gets strep throat most commonly? Little kids. And one thing that's not very specific, but it's a helpful association, is that these patients will often have brown urine from heme pigments in the urine and from the hematuria. So again, hematuria doesn't have to cause red, frankly bloody urine. It can just cause some brown urine, tea-colored urine, or sometimes it's called Coca-Cola urine. So we often see that with post-strep glomerulonephritis. So if they give you a child who presents with a history of strep infection or a history of an upper respiratory infection a few weeks before, and now he's got brown urine, think about post-infectious or post-streptococcal glomerulonephritis. Now, if you get a renal biopsy, which again, we usually don't get a renal biopsy in these patients because the history is pretty obvious, but if you did get a biopsy, you might see hypercellular glomeruli, so this is a proliferative process, right? There's going to be lots of neutrophils in the glomeruli. Immunofluorescence will show lumpy, bumpy deposits of those IgG and IgM immune complexes and also complement C3 that get deposited in the mesangium and they get deposited along the basement membrane. So these deposits are usually called subepithelial humps. You can usually see them better on the electron microscope. So let me walk you through this on a drawing and then we'll look at the real deal. This is a drawing of a normal glomerulus. And I want to start by orienting you to the different parts so that when we look at the abnormal ones, you know what you're looking at. These pinkish red cells are the endothelial cells of the glomerular capillaries, which have fenestrations that allow plasma to be filtered. The purplish cells are the epithelial cells with podocyte foot processes, nice uniform foot processes. This smooth green line is the basement membrane, which is sandwiched between the pinkish red endothelial cell and the purplish podocyte foot processes. Remember, those are the three layers that make up the glomerular filtration barrier: the endothelial cell, the negatively charged basement membrane, and the podocyte foot processes from the epithelial cells. Now this light brown region is the mesangium, or the mesangial matrix. And the darker brown cells inside the mesangium are the mesangial cells. So now let's walk through those changes we just listed for post-streptococcal glomerulonephritis. You see these subepithelial humps, these lumpy, bumpy immune complex deposits on the top of the basement membrane, right underneath the epithelial podocyte foot processes. And that's the key feature I want you to remember about the microscopic appearance of post-streptococcal glomerulonephritis. Lumpy, bumpy deposits, these subepithelial humps. We also have hypercellular glomeruli, so lots more mesangial cells than normal, and also some neutrophils within the glomeruli. Now, here's the real deal. This is a light micrograph, and all you can really make out here is the hypercellular mesangium, and there's some neutrophils in here. There's so many cells that you can't even really make out the capillaries distinctly, but you don't really see those lumpy, bumpy deposits on light microscopy. So here's the electron micrograph of a patient with post-streptococcal glomerulonephritis, and you can see these dark subepithelial humps kind of all over the place. It's not really very subtle if you know what they look like. And then again, you have a hypercellular mesangium, and the lumen of the capillaries are kind of compressed. So the L is marking the capillary lumen. A couple of other clinical points. These patients have activation of complement, which leads to destruction of the basement membrane. And this means that there's an overall decrease in complement C3 levels. And then one test that's traditionally been used to prove that the patient did in fact have a recent strep infection is a high anti-streptolysin O titer, or ASO titer. And that's fine for strep pharyngitis or strep throat. But patients with strep impetigo may not have an elevated ASO titer. It's typically not elevated in impetigo. But there's an antibody called anti-DNase B that is elevated both in strep throat and strep skin infections. So that may be worth knowing, anti-DNase B. Next I want to talk about IgA nephropathy, or Berger disease. Now remember, this is not the same as the vasculitis called Berger disease, or thromboangiitis obliterans that we talked about in cardio. Remember, that affects young male smokers. This is a different Berger disease. This is B-E-R-G-E-R, Berger disease. So a minute ago we had Coca-Cola urine, now we have Berger disease. So the next one is glomerulofrenchphritis. That's a combo meal, and we'll call it a day. Now IgA nephropathy is associated with a form of vasculitis called Henoch-Schönlein purpura, which causes a tetrad of palpable purpura on the buttocks and the legs, plus arthralgias, abdominal pain from intestinal hemorrhage, and renal disease. So you remember that? So the renal disease with HSP was IgA nephropathy. Now with IgA nephropathy, patients get increased serum IgA, and then IgA immune complexes get deposited in the mesangium. And they also have a proliferation of mesangial cells. On the electron micrograph, you can see these dark, dense deposits in the mesangium down here in the corner. This huge black blob is a red cell in the capillary, but these dense deposits in the mesangium are deposits of the immune complexes. IgA nephropathy typically presents with hematuria. When you examine the urine, you're going to see those red cell casts. And it often flares up after an infection like a URI, and we also saw that with Henoch-Schönlein purpura. Next, let's talk about Alport syndrome. We discussed Alport syndrome in the foundation section when we discussed collagen synthesis. Alport syndrome is due to a defect in type 4 collagen. So where do we find type 4 collagen? Well, the mnemonic was SCAB, S-C-A-B, and the B was for basement membrane. So when you look at the basement membrane in the glomeruli, you're going to see that the basement membranes thin out, then they split longitudinally. It's kind of hard to make it out on this electron micrograph, but just remember splitting of the basement membrane. And if you remember, in foundations when we talked about this, we used the mnemonic can't see, can't pee, can't hear, high C, because Alport syndrome causes a triad of eye problems like cataracts and lenticonus, causes nephritis and splitting of the basement membrane, and then deafness or high frequency hearing loss. So can't see, can't pee, can't hear, high C. Now let's talk about rapidly progressive glomerulonephritis, or RPGN. So these patients deteriorate fairly quickly and they progress rapidly to renal failure. That's why it's called rapidly progressive, because they get sick and all of a sudden they've got renal failure. It's also sometimes called crescentic glomerulonephritis. Again, these diseases are sometimes categorized by how they look histologically. So what do you think you're going to see on the histology of a patient with crescentic glomerulonephritis? Well, you're going to see crescent-shaped deposits in the glomeruli, made up of fibrin and complement and cellular debris. But there are several diseases that can cause this histologic appearance. One disease is Goodpasture disease, which you should remember is a type 2 hypersensitivity caused by antibodies against the glomerular basement membrane. So on immunofluorescence, you'll see a linear pattern of antibodies lining the basement membranes, following the outlines of the basement membrane. One student said it was like a fence running around the edges of a pasture for Goodpasture. Now, we've mentioned that Goodpasture is one of the few diseases that attacks both the kidneys and the lungs. In addition to nephritis, Goodpasture disease also causes pulmonary hemorrhage and hemoptysis. So if you see a patient with nephritis plus hemoptysis, think about Goodpasture. Another disease that attacks the kidneys plus the lungs is granulomatosis with polyangiitis, or GPA, which used to be called Wegener's granulomatosis. And it also causes this rapidly progressive or crescentic glomerulonephritis. And we talked about GPA with the vasculitides and cardiovascular as well. This is one of the ones that affects the kidneys and the lungs and the upper airway, like the sinuses and the hard palate. And we said that one of the classic features of GPA is a positive C ANCA, or PR3 ANCA. That's a big clue for GPA. A third disease that causes RPGN is something called microscopic polyangiitis, which is associated with a P ANCA, or MPO ANCA. And then lupus, which can cause lots of different patterns of nephritis, can certainly cause RPGN and this crescentic glomerulonephritis. Now that brings us to diffuse proliferative glomerulonephritis, which is the most common, most severe form of lupus nephritis. Again, diffuse just means that more than half of the glomeruli are involved, and proliferative means that the cells are proliferating. Now we've said before that anti-double-stranded DNA antibodies are associated with lupus nephritis, and that's what you see here both in the mesangium and also subendothelially, between the endothelium and the basement membrane. And because these deposits kind of line the basement membrane on light microscopy, this can make the basement membranes look really dense and pronounced, which is sometimes called a wire loop appearance. So I want you to remember the phrase wire lupus, which is the wire loop appearance commonly seen in lupus nephritis. And I'll just mention in passing that diffuse proliferative glomerulonephritis can present with a nephrotic syndrome-like picture. It's not always nephritic. They may have a lot of heavy proteinuria with this. All right, let's go ahead and work through the end of session quiz. First question. A teenager presents with episodes of gross hematuria and high-frequency hearing loss. What's the most likely diagnosis? Well, whenever you get kidney disease plus hearing loss, think about Alport syndrome. Can't see, can't pee, can't hear, high C. Next, an 8-year-old girl presents with abdominal pain, hip and knee pain, and purpura on the backs of the arms and legs. Urinalysis shows microscopic hematuria and mild proteinuria. What's the most likely diagnosis? So purpura, arthralgias, abdominal pain, and glomerulonephritis. This suggests Henoch-Schönlein purpura. And what type of nephritis is associated with HSP? IgA nephropathy. And then the last question says, which glomerular disease would you suspect most in a patient with the following findings? Now, this is really high yield. Definitely be able to match the biopsy findings to the diagnosis. Linear pattern of IgG deposition on immunofluorescence is Goodpasture disease with the anti-GBM antibodies. Lumpy, bumpy deposits of IgG, IgM, and C3 in the mesangium is post-streptococcal glomerulonephritis. Deposits of IgA in the mesangium is IgA nephropathy. Anti-GBM antibodies, hematuria, and hemoptysis is Goodpasture disease. Crescent formation in the glomeruli is rapidly progressive glomerulonephritis, also known as crescentic glomerulonephritis. And wire loop appearance on light microscopy is lupus nephritis. Remember the phrase wire lupus. That's it for now. I'll see you next time.
It's time for another 3-question warm-up. Let's get going. What nerve is most at risk of being damaged in a fibula neck fracture? That's going to be the common peroneal nerve, also known as the common fibular nerve. Next, which 2 muscle receptors are responsible for opening the sarcoplasmic reticulum in response to depolarization? Asking me the dihydropyridine receptor and the ryanodine receptor. Next question. What are the features of congenital syphilis? So there's several things. Think of snuffles. Remember, those are those blood-tinged kind of nasal secretions. Next, we have the saber shins. That's going to be anterior bowing of the tibia. A saddle nose deformity. That's going to be flattening of the nasal bridge or a collapsed nasal bridge altogether. And then also frontal bossing. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
We're talking about glomerular diseases, and we've already covered nephritis, so now we're going to discuss nephrotic syndromes. We said that the key feature of nephritis is inflammation, and hematuria as evidence of that inflammation. Then the key feature of nephrosis is heavy proteinuria. So how much proteinuria? What's the cutoff? More than 3.5 grams per day, which you measure by collecting the urine for a full 24 hours. Now, the other key features of nephrotic syndrome are hypoalbuminemia, because they're spilling out a lot of albumin out of the blood into the urine. They also have edema, because they've lost most of the albumin that provides all the oncotic pressure to keep fluid inside the vasculature. They also have increased risk of infection, because they're losing immunoglobulins in the urine, and increased risk of thrombosis, because they're losing the anticoagulant protein antithrombin in their urine. They can also have hyperlipidemia, because when the oncotic pressure starts to fall, it stimulates the liver to make more lipoprotein particles. We don't really know why or how exactly, but you can imagine the liver wanting to raise the oncotic pressure by any means available, so it tries putting more cholesterol into the blood. And somehow, nephrotic syndrome impairs the body's ability to metabolize triglycerides and get them out of the blood. So, even though heavy proteinuria is the most important diagnostic feature of nephrosis, there's this whole constellation of finding that's found, and which is why we call it nephrotic syndrome. It's a syndrome of lots of different findings. Now, the first disease I want to discuss that causes nephrotic syndrome is called minimal change disease. Now, it's called minimal change disease because the patient looks pretty sick clinically with all this edema and proteinuria, but then when you do the kidney biopsy looks pretty normal. You may see a little bit of flattening or effacement of the podocyte foot processes, but in general, you're not going to see much on the renal biopsy because this is minimal change disease. The changes you see are minimal. Now, on our drawing, everything looks pretty normal, except for some distortion and irregularity of the foot processes. Now, this distortion makes the glomerular filtration barrier more permeable to albumin, which is what leads to the proteinuria. Now, you should associate minimal change disease with children. It's by far the most common cause of nephrotic syndrome in children. Something like 75% of children with nephrotic syndrome have minimal change disease. Now, not a lot of children get minimal change disease, but if you see a young child with nephrosis, it's most likely going to be minimal change disease. Now, this can be triggered by infections or triggered by immunizations, but we don't really know why. It may have to do with the body generating some circulating immune factors. And we treat minimal change disease with corticosteroids. More than 90% of these kids will respond to steroids, so we usually give steroids empirically without getting a biopsy if they fit the clinical picture. If minimal change disease is the most common cause of nephrosis in children, what's the most common cause of nephrosis in adults? Well, that's a harder question to answer, believe it or not, but in the U.S., I believe it's a disease called focal segmental glomerulosclerosis, or FSGS. So it used to be that membranous nephropathy was more common. We're going to talk about that one next. But sometime in the 80s or early 90s, there was a shift toward more FSGS. So FSGS is definitely more prevalent in African Americans and also in Latinos. And you might say, well, as the U.S. has become more diverse and less predominantly white, a higher percentage of the population is black or Hispanic. So of course FSGS is going to become more common overall. But that's not the whole story, because even in whites there's been like a 13-fold increase in FSGS. So I don't know how important it is. Lots of books are going to say lots of different things. I honestly doubt you're going to be asked, what's the most common cause of nephrotic syndrome in adults? But be aware that FSGS is definitely up there, especially among blacks and Latinos. Now, the other group that gets a lot of FSGS is HIV patients. Definitely know that one. So if they give you an HIV positive patient with nephrotic syndrome, think about FSGS. So what are you going to see on biopsy? Well, you see sclerosis that is focal and segmental. It's focal segmental glomerulosclerosis. Again, the name kind of gives it away. So the sclerosis is focal. It affects less than half of the glomeruli, and it's segmental, which means that certain segments or regions of the kidney are going to be more likely to be affected than other regions. For instance, deeper glomeruli close to the medulla may be affected first, and then the glomeruli near the cortex may be spared. So it's segmental. There are also variants of FSGS where only one part of the glomerulus is affected, like you see here. So parts of this glomerulus look pretty normal, but then other parts are really pink and sclerosed. Now for years and years and years, the most common cause of nephrotic syndrome in adults in the U.S. was a disease called membranous nephropathy. And now, for whatever reason, that seems to not be the case anymore. C'est la vie. But it's still the most common cause of nephrosis in Caucasian adults. Now I mentioned that lupus can cause lots of different renal lesions, and membranous nephropathy is one of them. The big thing to remember is that on biopsy you're going to see thickening of the basement membrane. Membranous basement membrane. You're also going to have subepithelial immune deposits along the basement membrane. So here's our drawing, and the basement membrane is diffusely thickened. And then along the surface of the basement membrane, instead of being nice and smooth, it has these domes, which are the subepithelial immune deposits. And then in between the domes, there's so much thickening of the basement membrane that it pushes up between the domes and it looks like little spikes. So this is called a spike and dome appearance, and you should definitely recognize that. And here's what it looks like in the electron micrograph. You have a big, thick basement membrane, and you have the domes, which are the subepithelial immune deposits, and then the spikes in between. So remember, this is membranous nephropathy, so all these changes are clustered around the basement membrane. Next, I want to talk about membranoproliferative glomerulonephritis, or MPGN. Now this can cause both a nephritic picture with hematuria, but it can also cause nephrosis and heavy proteinuria, just like we saw with diffuse proliferative GN from lupus. Now, this is membranoproliferative. So again, the basement membrane is involved, and it's also associated with cellular proliferation. But I like to use the word membranoproliferative to think about the basement membrane proliferating. So instead of just one single solid basement membrane, you actually see two basement membranes, which gives it a doubled up train track or tram track appearance. Now on our drawing, we see some IgG immune complexes along the basement membranes. These are sometimes called subendothelial humps. Don't get that confused with the subepithelial humps that we saw with post-streptococcal glomerulonephritis or with the subepithelial domes we saw with membranous nephropathy. These are subendothelial humps. And then down here, the basement membrane has actually doubled up, and you see that tram track or train track appearance. And you can see the mesangium proliferating and invading the space between the two. There are also deposits in the mesangium, and the foot processes aren't normal. It's just like a bomb went off and everything's gone haywire. And here on electron microscopy, you can see the doubled up basement membrane at the top and that tram track appearance. And then toward the center, there are these dark immune deposits along the basement membrane and also in the mesangium. You also need to know several diseases that can lead to MPGN, which include hepatitis B, hepatitis C, lupus, and subacute bacterial endocarditis. Make sure you know all four of those, especially subacute endocarditis. Now, like lupus, diabetes can do a lot of different kinds of damage to the kidney. So when the blood glucose is high, glucose gets tacked onto a lot of different things, like hemoglobin, that's what makes hemoglobin A1C. Glucose gets tacked onto blood vessels, and it gets tacked onto the glomerular basement membranes. So this is a non-enzymatic glycosylation, which just means you don't need an enzyme to tack the glucose onto things. But that glycosylation of the basement membrane makes the basement membrane thick, makes it dysfunctional. And you're also going to see non-enzymatic glycosylation of the arterioles, which causes the mesangium to proliferate. But diabetic nephropathy leads to proteinuria. That may begin as microscopic albuminuria, just a tiny bit of microscopic albumin in the urine, but it can certainly progress to nephrotic syndrome if you don't recognize it and treat it. So with diabetes, you might see thickening of the glomerular basement membrane, and then you can see these round acellular nodules within the glomeruli in the nodular type of diabetic nephropathy. And these are called Kimmel-Steele-Wilson nodules. That's something you should definitely know. And the mesangium can be dramatically expanded. So here, on light microscopy, there's this round pink acellular nodule, which is a Kimmel-Steele-Wilson nodule. Definitely be able to recognize that as a feature of diabetic nephropathy. And you also see how dense the mesangium is through here. Not a lot of cells, but a ton of that mesangial matrix. And the capillaries aren't nearly as prominent as they would be in a healthy glomerulus. Then the very last disease I want to mention just briefly is amyloidosis. Now we've talked about amyloid before. Amyloidosis is a disease where you have these abnormal amyloid proteins that are deposited in various tissues, like in the kidney, and the heart, and the liver, the muscles, the brain. And all those amyloid fibrils just sort of bulk up the tissue. But in patients with systemic amyloid, the kidney is the most commonly involved organ. Now in our drawing, you can see massive expansion of the mesangial matrix, kind of like you saw with diabetes, and then tons of these amyloid proteins that are deposited in the mesangium. But the test you need to remember for amyloid is the Congo red stain. Congo red stain will cause the amyloid protein to light up bright green under polarized light, and that's called apple green birefringence. So this is a kidney biopsy from a patient with amyloid nephropathy. So be sure you can recognize what that looks like, and remember what stain is needed to produce that color. It's the Congo red stain. All right, before we do the end of session quiz, let's do a quick review of all the different glomerular diseases we've been studying. Hey, hey, hey! It's time for Buzzword Blitz, the fast-paced game that's fun for the whole family. The theme for today's game is glomerular diseases. All right, this should be fun. I'm going to list several key words or phrases, and I want you to give me the type of nephritis or nephrosis associated with them. And don't forget to shout out those answers really loud. Let everybody know just how smart you are. Ready to play? The first one, nephrotic range proteinuria, thickened basement membrane spikes, and subepithelial domes. That's membranous nephropathy. Next one, train tract basement membrane, subendothelial humps, mesangial cell proliferation, and hepatitis B. This one's membranoproliferative glomerulonephritis. All right, next one, subepithelial humps, also known as those lumpy bumpy deposits, decreased complement 3 levels, Coca-Cola urine, and positive anti-DNase B titers. That's post-streptococcal glomerulonephritis. Next one, may occur after upper respiratory infection, Henoch-Schönlein purpura, also known as Berger disease, and mesangial deposits of IgA. This is IgA nephropathy. Next one, protein deposits in the heart, liver, and kidney, associated with multiple myeloma, and apple green birefringence. That's amyloidosis. Next one, defect in type 4 collagen, cataracts, nephritis, and high-frequency hearing loss. That's Alport syndrome. Can't see, can't pee, can't hear, high C. Next one, diffuse proliferative glomerulonephritis, anti-double-stranded DNA antibodies, and wire loop basement membranes. That's lupus nephritis. Next one, microscopic hematuria, pulmonary infiltrates, type 2 hypersensitivity, and anti-glomerular basement membrane antibodies. That's Goodpasture syndrome. Next one, hematuria and proteinuria, pulmonary infiltrates, nasopharyngeal granulomas, and C. ANCA, that's granulomatosis with polyangiitis, or Wegener's. Next one, proteinuria and edema, podocyte foot process effacement, most common cause of nephrotic syndrome in children, and treat with corticosteroids, that's minimal change disease. All right, common cause of nephrotic syndrome in HIV patients, common cause of nephrotic syndrome in blacks, and common cause of nephrotic syndrome in Latinos, and the most common cause of nephrotic syndrome in U.S. adults. This is focal segmental glomerulosclerosis. So that's our game for today. Thanks for playing Buzzword Blitz. All right, now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go through the answers together. First question, what are the defining features of nephrotic syndrome? So you have to have proteinuria greater than 3.5 grams per day, you can have hypoalbuminemia, and then peripheral edema. And again, these patients also have some hyperlipidemia and increased risk of infections and so on, but the three things you have to have in order to meet the criteria for nephrotic syndrome are heavy proteinuria, hypoalbuminemia, and peripheral edema. Next, glomerular histology reveals multiple mesangial nodules. This lesion is indicative of what disease? Now, these are Kimmel-Steele-Wilson nodules. This indicates diabetic nephropathy. And again, the last question with the biopsy findings, definitely high yield for you to know. Which glomerular disease would you suspect most in a patient with the following findings? So the most common nephrotic syndrome in children is minimal change disease. The most common nephrotic syndrome in adults is FSGS, or focal segmental glomerulosclerosis. Electron microscopy shows effacement of the epithelial foot processes. That's going to be minimal change disease. Nephrotic syndrome associated with hepatitis B is membranoproliferative glomerulonephritis, or MPGN. Nephrotic syndrome associated with HIV is FSGS. Electron microscopy shows subendothelial humps and the tram track appearance. That's MPGN, membranoproliferative glomerulonephritis. Remember, membranoproliferative sounds like the membrane is proliferating, which means it's doubled up. And again, it looks like a train track or tram track. Light microscopy shows segmental sclerosis and hyalinosis. Again, that's focal segmental glomerulosclerosis. Purpura on the back of the arms and legs, abdominal pain, and IgA nephropathy. That's Henoch-Schönlein purpura. Apple green birefringence with Congo red stain under polarized light is amyloidosis. And electron microscopy shows spiking of the glomerular basement membrane due to electron-dense subepithelial deposits. That's membranous nephropathy. Remember that spike and dome appearance. So make sure you know those. Make some flashcards if you have to, but know those buzzwords. So that's it for nephrosis. I'll see you next time.
It's time for another warm-up. Let's get going. So which antibiotics inhibit prokaryotic protein synthesis at the 30S ribosomal subunit, and then which ones at the 50S ribosomal subunit? So the mnemonic that we've been using is buy at 30, sell at 50. The A in the AT is for aminoglycosides. Think of things like gentamicin and tobramycin. The T is for the tetracyclines. Now let's move on to the 50. So sell at 50, CCELL. The first C is for chloramphenicol. The second C is for clindamycin. E is for erythromycin and the other macrolides like azithromycin, chlorothromycin. Lincomycin is another one. Linezolid is another one. And then also think of the streptogrammins. Next question. What are the criteria for the diagnosis of a major depressive episode? So remember, you need to have 5 out of the 9. So Diggs-Capes is one of the mnemonics we've used. So D is for depressed mood, also diminished interest, so anhedonia, feelings of guilt or worthlessness, sleep disturbance, impaired concentration, appetite changes, psychomotor agitation or retardation, loss of energy, so fatigue, suicidal ideation. So you have to have 5 of those, or at least for at least 2 weeks, and then one of the symptoms must include either a depressed mood or anhedonia. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture.
Welcome to our video on kidney failure. Now, before we get started, we've been developing some new technology to provide our lectures in immersive, lifelike 3D. So I want you to put on your 3D glasses and go ahead and enable the DIT and 3D plugin in your web browser. And DIT is now in 3D. It's not a cheap gimmick. It's totally enhancing the educational experience. What do you think? Me either. The term kidney failure encompasses both acute kidney injury and chronic kidney disease, or chronic kidney failure. Now, we're going to discuss several causes of kidney failure that aren't really covered elsewhere in the course. For example, you can have kidney failure from glomerulonephritis or nephrotic syndrome, but we cover those separately. We're not going to rehash all that right now. So let's start with acute kidney injury. Acute kidney injury occurs when there's some injury or disease of the kidneys that causes a sudden decline in renal function and a sudden rise in the BUN and creatinine. We used to call this acute renal failure, but now we call it acute kidney injury because the kidneys don't have to completely fail. But if the baseline creatinine is 0.5 and it suddenly goes to 2.5, that's acute kidney injury, even though technically the kidneys are still functioning somewhat. They haven't failed altogether. Or sometimes patients will have some chronic renal insufficiency, and the baseline creatinine is around 2.5. And then suddenly the creatinine goes up to 4.5. So that's acute kidney injury superimposed on chronic renal insufficiency. It's useful to divide acute kidney injury into three broad categories based on what causes it: pre-renal azotemia, intrinsic renal disease, and post-renal azotemia. Azotemia just means excessive nitrogen compounds in the blood. Azo is nitrogen, right? So when the BUN, or blood urea nitrogen, is elevated, that's azotemia. It's just a fancy word for high BUN, because in medicine we like to make things unnecessarily complicated. So for the moment, I want you to think of the kidney as a bean-shaped factory that filters blood and converts plasma to urine. Pre-renal azotemia occurs when something reduces the inflow of blood. It's pre-renal. The problem is occurring before you get to the kidney itself. The actual blood filtering and urine-making equipment of the kidney is working just fine. The problem is upstream from the kidney. Then post-renal azotemia occurs when there's a problem with the outflow of urine, some obstruction downstream from all that urine-making equipment. And then intrinsic renal disease means that the problem is in the urine-making equipment itself, the glomeruli and the nephrons. There's something intrinsically wrong with the kidneys themselves. Pre-renal azotemia is very common, especially in hospitalized patients. Causes include things like hypovolemia, such as acute blood loss or diarrhea. Or you might see pre-renal azotemia from hypotension, such as in the case of CHF and decreased ejection fraction, or from portal hypertension and arterial vasodilation. Sepsis or cardiac arrest can also lead to hypotension and pre-renal azotemia. And you might even see it from excessive NSAID use, because NSAIDs inhibit prostaglandin synthesis and lead to some vasoconstriction of the afferent arterioles. But the bottom line is that there's underperfusion of the kidneys. So say you have a patient who codes and you resuscitate them, but the next day the BUN and creatinine starts rising. That's probably pre-renal acute kidney injury. Now, intrinsic renal diseases that cause acute kidney injury include things like glomerulonephritis, which affects the glomerulus, acute tubular necrosis, which affects the epithelial cells of the nephron tubules, and acute interstitial nephritis, which affects the interstitial tissue around the tubules and the glomeruli. There are certainly more causes of this, but those are the big ones, especially glomerulonephritis, which is covered in a separate video, and also ATN, which we're going to cover in a little bit. And then post-renal azotemia means there's some urinary tract obstruction, which is often due to prostate disease in men, either BPH or possibly prostate cancer, other urinary tract neoplasms such as bladder cancer, or congenital anomalies, or even kidney stones. And you really need bilateral obstruction to result in acute kidney injury and azotemia. If there's a mass or a stone affecting just one kidney, the other one can usually pick up the slack and keep the BUN and creatinine under control. So when you're seeing a patient with an elevated BUN and creatinine, how do you determine if it's pre-renal or post-renal or intrinsic renal disease? Well, the classic test is called the fractional excretion of sodium, or the FENA. Now, before we look at the formula, I will say I don't know this calculation to be high yield for step 1. They may calculate it for you. And even though you can look up the formula when needed, I guarantee this is going to come up during your internal medicine clerkship, because acute kidney injury is very common in the hospital. So I'm going to go over it briefly because I don't know that calculating it is high yield, but you should be able to interpret it for your exam. The FENA, or fractional excretion of sodium, is basically the fraction or percentage of the sodium in the filtrate that ends up being excreted in the urine. And you calculate it by multiplying 100 times urine sodium times serum creatinine divided by serum sodium times urine creatinine. I remember that the small numbers go on top and the bigger numbers go on bottom. Urine sodium is smaller than serum sodium. Serum creatinine is a lot smaller than urine creatinine. When you calculate it, the FENA is normally around 1%. In pre-renal disease, the FENA is generally low, less than 1%. And in acute tubular necrosis, which is the most common cause of intrinsic renal disease, the FENA is generally high, greater than 2%. It's not always the case, but it's a decent rule of thumb. Now, I hate to memorize something if I can simply reason it out instead. So think about pre-renal disease. There's underperfusion. Either the blood pressure is low or the intravascular volume is low. And remember, the urine-making equipment inside the kidney is basically fine. So how does the kidney respond to inadequate perfusion? By retaining sodium and retaining water and expanding the intravascular volume. So if the kidney is reabsorbing sodium, taking it out of the filtrate and putting it back into circulation, the fractional excretion of sodium will be low, and urinary sodium is low. So pre-renal kidney disease leads to a low FENA. But if there's intrinsic renal disease, that diseased kidney can't reabsorb sodium normally. So more sodium ends up in the urine, and fractional excretion of sodium is high. That's how I think about it. Another potentially useful lab for differentiating pre-renal from intrinsic renal disease is that in pre-renal disease, the ratio of BUN to creatinine is usually high, greater than 20:1. In addition to reabsorbing sodium, the kidneys will reabsorb more urea in pre-renal disease, so that BUN to creatinine ratio is higher. Definitely know that. In intrinsic renal disease, the ratio is in the range of 10:1 or 15:1. Normal BUN is around 10 to 14, and normal creatinine is around 1. So the normal BUN to creatinine ratio is 10 or 15:1. And what about post-renal disease? Well, it's harder to diagnose with labs because the lab results are variable. But you can do imaging like an ultrasound to look for evidence of hydronephrosis or dilated ureters or bladder distension. Let's talk about the results of renal failure. So what happens to a patient when the kidney starts shutting down? Well, first think about what healthy kidneys do. They handle fluid balance, electrolyte balance, they keep the pH balanced, they activate vitamin D, which influences calcium absorption in the GI tract. They produce erythropoietin, which is a hormone that stimulates red cell production in the bone marrow. And the kidneys excrete urea, which is a nitrogen-containing waste product from protein and amino acid metabolism. So in kidney failure, we can see volume overload, resulting in peripheral edema, pulmonary edema, heart failure, hypertension. One of the more significant electrolyte abnormalities is hyperkalemia. That's a big problem in kidney disease. High phosphates or hyperphosphatemia is also a problem, but hyperkalemia is a more life-threatening acute problem. And so is metabolic acidosis. Now, if the kidneys don't activate vitamin D, that leads to a metabolic bone disease called renal osteodystrophy. We're going to talk about that separately. Anemia can occur from decreased production of erythropoietin. And we said that excess urea is called azotemia, but when that urea gets really high, it causes something called uremia. Uremia is a syndrome that includes anorexia, nausea and vomiting, skin changes, pericarditis, platelet dysfunction and an inability to stop bleeding, and encephalopathy, which could manifest as lethargy, confusion, seizures, coma, and death. And chronic kidney disease also leads to hypertriglyceridemia. It's not fully understood why, although it seems to have something to do with impaired clearance of triglycerides from circulation. So some of these, like volume overload and hyperkalemia and metabolic acidosis, are seen with both acute kidney injury and chronic kidney disease. But metabolic bone disease, anemia, uremia, and hypertriglyceridemia are pretty much exclusive to chronic kidney failure. Let's spend a moment thinking through renal osteodystrophy. The kidneys are responsible for activating vitamin D by adding a hydroxyl group to 25-hydroxyvitamin D to make 1,25-dihydroxyvitamin D, or calcitriol, which is the biologically active form of vitamin D. So in kidney failure, this activation doesn't take place as efficiently, which means the patient can't absorb calcium as well in the GI tract. And then as serum calcium decreases, the parathyroid glands produce more parathyroid hormone. So this is a form of secondary hyperparathyroidism. And that parathyroid hormone induces bone resorption to help maintain the serum calcium level. So we call this renal osteodystrophy. There's tissue degeneration or dystrophy of the bones, with thinning of the bones and sometimes abnormal mineralization. We generally treat this with calcium and vitamin D supplements. Next, let's talk about some intrinsic kidney diseases that can cause renal failure. Intrinsic diseases include mainly glomerulonephritis, which are covered elsewhere, and tubulointerstitial diseases, which affect the nephron tubules or the interstitial tissues. These are not nearly as high yield as glomerulonephritis, but let's hit the highlights of these, starting with acute tubular necrosis. Acute tubular necrosis, or ATN, is acute necrosis or death of the epithelial cells that form the renal tubules. This is one of the most common causes of acute kidney injury, especially in hospitalized patients. So the patient suffers some insult that causes the tubular epithelium to die, and then the patient becomes oliguric, the BUN and creatinine rise, and then they become acidotic and hyperkalemic. This is potentially fatal, and then if they survive, the acute kidney injury could last for 2 or 3 weeks before the BUN and creatinine start to fall, the patient starts making urine again. So what kinds of insults cause this tubular necrosis? Well, the two big categories are ischemia and nephrotoxins. Take a look at your study guide. Ischemia can result from prolonged hypotension, sepsis, particularly septic shock, blood loss, surgery, particularly surgery to repair an aortic aneurysm where you have to cross-clamp the aorta. And then CHF is an unusual cause of ATN for reasons that are not entirely clear. Now, renal ischemia starts off as a pre-renal injury, technically, but that ischemia can damage the tubules and lead to ATN that will persist even when renal perfusion has been restored. So if you have a patient that gets septic and the BUN and creatinine starts to rise, But even a week later, after you've corrected the sepsis and you're perfusing the kidney just fine, the BUN and creatinine stay elevated, that's more likely ATN secondary to sepsis and ischemia rather than prolonged pre-renal azotemia. And what labs might help you figure that out? The FENA, which is going to be high in ATN and low in pre-renal azotemia. And then also the fact that the BUN stays elevated despite correcting the volume depletion. That suggests something other than pre-renal azotemia. Then besides ischemia, the other big category of things that cause ATN is nephrotoxins. This includes drugs like aminoglycosides and the cancer drug cisplatin. There are more drugs that do this, but they're uncommonly used drugs, things like pentamidine and foscarnet. And then another important nephrotoxin is radiocontrast that we use for CTs or angiograms. We really don't know why IV contrast causes ATN, but it does. Then another big one is myoglobin, specifically in the setting of rhabdomyolysis. So rhabdomyolysis occurs when there's massive muscle breakdown from a crush injury or prolonged seizures or a heat stroke or cocaine use, or even rarely from statins. And as the muscle breaks down, myoglobin spills into the blood, and then that myoglobin goes to the kidneys. The myoglobin gunks up the kidneys, and that leads to acute tubular necrosis. And then one recent development is that some synthetic cannabinoids like K2 or spice can potentially cause direct nephrotoxicity in ATN. And that may also cause rhabdomyolysis. The kidney biopsy may show sloughing of the tubular epithelium cells into the lumen of the tubule. So instead of the tubules being nice and open looking, they sort of look constricted or clamped down. You should also know that ATN classically causes muddy brown casts in the urine. We'll talk about casts in detail later, but remember, muddy brown casts with ATN. Another intrinsic renal disease is acute interstitial nephritis, which is also called drug-induced interstitial nephritis or allergic interstitial nephritis or tubulointerstitial nephritis. It's got a little bit of an identity crisis, but I'm going to stick with acute interstitial nephritis or AIN. AIN is nephritis, or inflammation of the kidney, that affects the interstitial tissue, the cells and support tissue that surrounds the tubules. You can remember the typical presentation of AIN with the word fear: fever, eosinophilia, azotemia, and rash. Now, we looked at this in immunology when discussing causes of eosinophilia. So here are the tubules, and then in the interstitium there are lots of inflammatory cells and plenty of eosinophils. So fever, eosinophilia, azotemia, and rash. It's sort of a diffuse maculopapular rash. It's a drug rash, an allergic rash. The most common cause of AIN is drugs or medications. Remember, it's sometimes called drug-induced interstitial nephritis. So the most common offenders are NSAIDs, penicillins and cephalosporins, ciprofloxacin, rifampin, which is used for TB mostly, sulfonamides like TMP-SMX, diuretics, many of which are also sulfonamides, PPIs, cimetidine, and the gout drug allopurinol. There are also some other conditions that can cause AIN, like lupus and sarcoidosis and certain bacterial infections, but the main cause to know are the drugs. And then we treat AIN by stopping the drug that caused it and possibly by giving some high-dose steroids for about 2 weeks and then gradually tapering off. But often AIN will resolve on its own once you stop the drug. Another renal pathology is renal papillary necrosis, where there's renal ischemia that leads to necrosis of the renal papillae and then they slough off. This usually causes gross hematuria, which may or may not be associated with flank pain, and also azotemia and hypertension. It can be triggered by pyelonephritis, by the use of analgesics, especially acetaminophen and possibly NSAIDs, by diabetes, and sickle cell disease. And the last pathology is diffuse cortical necrosis, or renal cortical necrosis. So this is acute generalized cortical infarction of both kidneys, which is pretty rare nowadays. It was classically seen in pregnancy as a complication of placental abruption or amniotic fluid embolism or massive obstetric hemorrhage. But basically, these things would trigger arterial vasospasm and renal ischemia, plus DIC, or disseminated intravascular coagulation. And then the patient would develop flank pain, because ischemia is painful, plus hematuria and oliguria, and possibly anuria. Let's finish up with urinary casts. Casts are often difficult to identify, but they can be helpful diagnostic clues. In the study guide it says, in which diseases are each of the following types of urinary casts commonly seen? Well, first of all, what are casts? Casts are made up of TAM horsefall mucoprotein, which is secreted by the tubular epithelial cells. And under the right conditions, this mucoprotein will accumulate in the distal convoluted tubules and in the collecting ducts, and then be sloughed off into the urine. you'll see they basically have formed little casts of the tubules, which may or may not have cells embedded in them. And the presence of certain types of casts in the urine can indicate certain disease states. The first one is hyaline casts, which are basically transparent and pretty hard to see. You can see hyaline casts in normal patients with no renal disease if the urine is concentrated. If they have low flow of urine, they're not flushing out all that TAM horsefall mucoprotein and it builds up a little bit. Or if they're on diuretics, they get a little dehydrated. So basically, other types of casts will form when cells and cellular debris are embedded in the hyaline cast. So hyaline casts are not pathologic. RBC casts indicate there's some type of glomerular bleeding, such as glomerulonephritis. These will appear yellowish brown in color, with red cells embedded in the cast. Now, don't get this confused with red blood cells. This is not the same thing as hematuria. Red blood cells in the urine can indicate pathology anywhere in the urinary tract. Red cell casts indicate pathology up in the kidney. White cell casts are seen in tubular interstitial disease, like acute interstitial nephritis, and also in acute pyelonephritis. And they can sometimes be seen in glomerular disorders, like proliferative glomerulonephritis. So anything where you have white cells and inflammation. But pyelonephritis is probably the most important one for you to know for step 1. Now, I know these look very similar to red cell casts. They may not ask you to identify the cast based on the picture, but they might tell you something like microscopic examination of the patient's urine reveals the presence of white blood cell casts. Epithelial cell casts are seen in acute tubular necrosis because those necrotic epithelial cells get stuck in the cast. Epithelial cell casts will also turn up in acute interstitial nephritis and in certain types of glomerulonephritis. Granular casts are somewhat nonspecific, but they're most commonly associated with acute tubular necrosis. Granular casts occur when you have breakdown of cellular casts. So anything that causes red cell casts or white cell casts or epithelial cell casts could also cause a granular cast as that cellular debris is being broken down. So the debris embedded in the cast can be fine, like you see here, or it can be coarse. And the casts have a sort of dirty brown appearance, and they're sometimes called muddy brown casts. So when you see those muddy brown casts, think ATN. Fatty casts are hyaline casts that have fat globules embedded in them from epithelial cells that have degenerated. We typically see these in nephrotic syndrome. And if those lipid globules contain cholesterol, that may show up as a Maltese cross when you view it under polarized light. And then waxy casts represent the further degeneration of granular casts, and these are fairly nonspecific. They can be seen in a variety of kidney diseases, but they're associated with very low flow states, like end-stage renal disease. Now it's time for the end of session quiz. So pause the video, work through those questions, and then we'll go over the answers together. First question, what is the classic presentation of acute interstitial nephritis? Remember the mnemonic FEAR: fever, eosinophilia, azotemia, and rash. Next, what drugs are known to cause acute interstitial nephritis? We talked about NSAIDs, which is the main one, then several types of antibiotics, penicillins, cephalosporins, ciprofloxacin, rifampin, and sulfonamides, and then diuretics, PPIs, cimetidine, and allopurinol. The last question, what changes will be seen in a basic metabolic panel in a patient with renal failure? So the main changes to know about are elevated BUN and creatinine, potassium is often elevated, calcium may be low, and if there's metabolic acidosis, the bicarb may be low. I think these things are broken. I'll see you next time.
It's time for another warm-up. Let's get going. What are the potential side effects of lithium? Well, it can cause polyuria and nephrogenic diabetes insipidus. It can cause arrhythmias like a sick sinus syndrome and even an AV block. It can cause hypothyroidism. It can cause lots of nonspecific kind of CNS things like a tremor, sedation, lethargy, and dizziness. And you should definitely know that lithium is teratogenic. It can cause the Epstein anomaly, which is that cardiac anomaly of the tricuspid valve and the RV as well. Next, which enzyme matches amino acids to tRNA? So it's going to be the amino acyl tRNA synthetase. Next, which drug intoxication or withdrawal is the most likely cause of each of the following sets of findings? So first we have anxiety, depression, delusions, hallucinations, flashbacks. That's going to be LSD intoxication. Next we have belligerence, impulsiveness, nystagmus, homicidal ideation, psychosis. That's going to be PCP intoxication. Next we have pinpoint pupils, nausea, vomiting, seizures. Think of opioid intoxication. severe depression, headache, fatigue, insomnia, or hypersomnia, and hunger, this is going to be cocaine or amphetamine withdrawal. That's it for the warm-up. Let's get to that lecture now.
Let's wrap up the renal section with a handful of unrelated topics, starting with pyelonephritis. Technically, acute pyelonephritis means inflammation of the renal cortex and the interstitium. But when we use the term pyelonephritis, we mean infection of the kidney. And we touched on this in micro when we discussed urinary tract infection because this is a type of upper urinary tract infection. There may be some urinary symptoms like dysuria or frequency, although those are typically associated with cystitis or lower urinary tract infection. Pyelo tends to be more severe, and it causes fever and chills, nausea and vomiting, possibly some flank pain. These patients may also become septic, and they can get very, very sick. Physical exam may show costovertebral angle tenderness, or CVA tenderness, which is where you thump lightly on the patient's back where the lower ribs meet the vertebral column. So it's the costovertebral angle. And that's tender, because that's roughly where the kidneys are situated. Urinalysis will show evidence of infection, especially pyuria, or white cells in the urine. And if you see white blood cell casts in the urine, that means you have white cells not just in the bladder, but also in the upper urinary tract, in the tubules where the casts are formed. So white cell casts in the urine are a good clue that there's some inflammatory process in the upper urinary tract. If the patient has recurrent episodes of acute pyelonephritis, he or she could develop chronic pyelonephritis, especially if there's urinary obstruction from kidney stones or vesicoureteral reflux, which just makes it harder for the body to flush the bacteria out of the kidneys. The classic pathology that you can see with chronic pyelo is called thyroidization of the kidneys, where the tubules fill up with eosinophilic casts so that the kidney resembles thyroid follicles, which are filled with colloid. Next, let's discuss renal cysts. Renal cysts are little fluid-filled sacs within the kidney. They're pretty common, and we often find them incidentally when we get an ultrasound or a CT for something else. They can be isolated, single cysts, or there could be lots of them. Some cysts are just simple cysts, fluid-filled, asymptomatic, typically inconsequential. They tend to be located peripherally on the cortex. But if the cyst has a solid component, or if they have septations, which are walls within the cyst kind of dividing it into separate compartments, or multiple cysts stuck closely together, that's called a complex cyst. We usually keep an eye on complex cysts with serial imaging to see if they're growing or changing, or we just remove them surgically to make sure they're not cancerous. Now, in your study guide, there's some information about a couple of diseases that produce lots of cysts. First, there's autosomal dominant polycystic kidney disease, which typically presents in adulthood. In fact, it used to be called adult polycystic kidney disease. It's most commonly caused by a mutation in the gene PKD1 for polycystic kidney disease, PKD. And this is found on chromosome 16, or rarely it's a mutation in PKD2, which is on chromosome 4. It causes many, many cysts to form in both kidneys and massive enlargement of the kidneys, up to 5 times the normal size. These patients usually present with hypertension and renal insufficiency, which gradually worsens as the disease progresses. These patients frequently develop end-stage renal disease and end up on dialysis. They can also have hemorrhage into the cyst, which causes flank pain and sometimes hematuria. They're also at increased risk of kidney stones and urinary tract infection. They can also have cysts in the liver and intracranial aneurysms, and even mitral valve prolapse or other heart valve disorders. Autosomal recessive polycystic kidney disease is due to a different mutation, and it typically presents in infancy, or these days it's found prenatally on ultrasound. The kidneys are bilaterally enlarged and echogenic, and this is associated with oliguria and oligohydramnios, which can lead to Potter sequence. And at birth, these patients often have hypertension and renal insufficiency, and also some hepatomegaly and liver problems. There's also a rare disorder called tubulointerstitial kidney disease, which was formerly called medullary cystic kidney disease. This is also inherited in an autosomal dominant fashion, but unlike polycystic kidney disease, which causes massive enlargement of the kidneys, this causes small, shrunken kidneys with fibrosis of the interstitial tissue. And rarely, the tubules can dilate and cause cysts in the medulla rather than in the cortex. And again, these patients have progressive renal failure. Let's talk about nephrolithiasis, or kidney stones. Kidney stones occur when various minerals and chemicals precipitate out of the urine within the kidney, and they form jagged little rocks that can scrape and cut the collecting system as they move along, or they eventually reach a point in the urinary tract that's narrower than the diameter of the stone, and they either cause obstruction or the smooth muscle in the ureter contracts around the stone and causes pain. We'll talk more about the clinical manifestations shortly, but first let's talk about the different types of stones. By far the most common type of kidney stone is calcium stones. They can be composed of calcium oxalate, which is most common, or calcium phosphate. And actually, many stones have mixed compositions, so they might have a mix of calcium oxalate and calcium phosphate, or calcium oxalate and some struvite, or whatever. Calcium stones tend to occur when there's hypercalciuria, which means excess calcium in the urine. It's hypercalciuria. This can occur with hypercalcemia, or high calcium in the blood, such as in hyperparathyroidism and certain cancers like squamous cell lung cancer or multiple myeloma. But you don't have to have hypercalcemia. Sometimes patients will have normal serum calcium but high urine calcium. Now, obviously, high oxalate levels in the urine can predispose to calcium oxalate stones. Ethylene glycol or antifreeze is metabolized to oxalate, among other things, so ingestion of antifreeze can predispose to calcium oxalate stones. And it's also worth knowing that Crohn's disease increases the risk of these stones because in a roundabout way, malabsorption leads to increased oxalate absorption. Crohn's can also predispose to other types of kidney stones, but calcium oxalate stones seem to be the most tested ones.
And if you have citrate in the urine, that helps to prevent the formation of calcium oxalate stones. So low urinary citrate, or hypocitraturia, can increase the risk of calcium stones. This is why type 1 RTA causes kidney stones, high urine pH and low urine citrate.
You should also know that ingesting massive doses of vitamin C can predispose to calcium oxalate stones. Now, both calcium oxalate stones and calcium phosphate stones are radio-opaque, meaning you can see them on plain film x-rays. Calcium in bones is opaque on x-ray, and so is calcium in kidney stones. We're going to look at the shape of the crystals in a moment. You can help prevent recurrent calcium stones by giving a thiazide diuretic, which decreases calcium in the urine. Remember, loops lose calcium, but thiazides help you retain calcium. They promote the reabsorption of calcium from the filtrate so that there's less calcium in the urine. Now, before you panic, I want to remind you that calcium oxalate stones are by far the most common type of kidney stone. So I'm not going to go into near as much detail about the rest of these. The next type of stone is ammonium magnesium phosphate stones, which are sometimes called struvite stones. These occur when certain bacteria, which have an enzyme called urease, break down urea in the urine into ammonia plus carbon dioxide. And that ammonia raises the pH of the urine. Urine pH is normally slightly acidic, but here it becomes slightly alkaline. And then that ammonia is converted to ammonium, and that binds to phosphate in the urine to form ammonium phosphate. And that can bind to magnesium to form ammonium magnesium phosphate, or struvite. So what bacteria have urease? Well, the main ones are Proteus mirabilis and Klebsiella, but Staph saprophyticus and others can lead to struvite stones as well. But when you see a urinary tract infection with a urine pH of 8 or higher, think about Proteus. Struvite stones are radio-opaque, and they classically form staghorn calculi, which are when stones sort of fill up the renal pelvis, and they look a little bit like the antlers of a deer or a stag. These aren't likely to pass on their own, so they may need to be removed surgically. There's a genetic condition called cystinuria, in which the kidneys can't reabsorb the amino acid cysteine in the proximal convoluted tubule. So these patients develop cystinuria and cysteine stones. This typically presents in childhood, and these can form staghorn calculi as well, but these are somewhat radiolucent. So you're not going to see them very well on the x-ray, but you can still see them on ultrasound. We treat cystinuria by alkalinizing the urine, which increases cysteine solubility so that it doesn't precipitate out of the urine and form stones. And then uric acid stones are associated with hyperuricemia and gout, as you might guess. And these stones are also radiolucent. It may also be worthwhile for you to know how to identify the shapes of these different crystals on microscopic examination of the urine. Now, we've drawn them for you in the study guide, but let's look quickly at the real deal. Calcium oxalate crystals are classically described as having an envelope shape, sort of a square with a big X in the middle. Struvite stones are described as having a coffin lid shape, which I find unnecessarily morbid. They look a little bit more like individual sections of a Hershey's chocolate bar to me. Cysteine stones are little hexagons, and uric acid stones can either form rhombuses or rosettes, where the rhombuses group together in a circular radial arrangement, kind of like spokes coming off a central hub. Now, for the clinical presentation, I mentioned that kidney stones can cause tissue damage as they pass through the urinary tract. And this can lead to hematuria, flank pain, and abdominal pain or back pain that radiates to the groin. The pain can be really severe, and these patients often you see them writhing in the bed because they can't get comfortable in any position. And stones can become impacted, especially at the ureterovesical junction, or possibly higher up in the ureter. And if the stone obstructs urine outflow, that can lead to hydronephrosis or even pyelonephritis. Hydronephrosis occurs when there's downstream urinary obstruction, and then proximal to the obstruction, the renal pelvis and calyces become dilated and distended. The backup of urine can damage the affected kidney, but the BUN and creatinine will only rise if both kidneys are affected, like with BPH, or if the patient only has one kidney. Basically, if there's unilateral hydronephrosis, the other kidney will pick up the slack. Let's discuss some tumors of the urinary tract, starting with renal cell carcinoma. This is the most common primary renal malignancy, or tumor of the kidney itself. It originates in the renal cortex, in the cells of the proximal convoluted tubules. Renal cell carcinoma is more common in men in their 50s and 60s. Risk factors include smoking, obesity, and hypertension. And while it often arises sporadically, it can also be seen as part of von Hippel-Lindau disease with a deletion mutation on chromosome 3. Von Hippel-Lindau causes a variety of tumors, such as hemangioblastomas, renal cell carcinoma, and pheochromocytoma, even in childhood. These cancers are often asymptomatic, and these days they're usually found incidentally, but they may cause a classic triad of flank pain, hematuria, and a palpable abdominal mass. Now that's considered the classic triad, but it's actually seen in fewer than 10% of patients. But patients may have one or two of those symptoms. Renal cell carcinoma is also notorious for causing some paraneoplastic syndromes. It can cause polycythemia, or erythrocytosis, because of excess erythropoietin production. Again, that's a classic paraneoplastic syndrome, and it's worth knowing, but it's actually only seen in about 5% of patients. It's much more common for these patients to have anemia. And then the tumor can produce PTH-related peptide, which results in hypercalcemia. And mets to the bone can also cause some hypercalcemia. Renal cell carcinoma is a solid tumor, and on biopsy it's characterized by clear cells that are full of lipids and carbohydrates. Another solid tumor that you might see on imaging is a benign tumor called an oncocytoma. There are two things you should know about this that are important differences from renal cell carcinoma. First of all, it's benign, and second of all, instead of those lipid-filled clear cells, oncocytomas are composed of densely packed eosinophilic cells, and these cells are arranged into little nests. But you should be able to see how different these look side by side. Renal cell carcinoma has clear cells, oncocytoma has densely packed eosinophilic cells. Wilms tumor is the most common renal malignancy of childhood. It's usually seen in early childhood, ages 2 to 4. Wilms tumor is also known as nephroblastoma. It usually presents with a palpable abdominal mass or a flank mass, and possibly some abdominal pain or hematuria. So the presentation is fairly similar to renal cell carcinoma. The main difference is the patient's age. Wilms tumor is associated with a mutation of the tumor suppressor gene WT1 or WT2, which are located on chromosome 11. You can remember WT is for Wilms tumor. There's also something called the WAGR complex that's associated with this gene mutation. WAGR stands for Wilms tumor, aniridia, which is a congenital absence of the iris. The G is for genitourinary malformations like cryptorchidism or a bicornuate uterus. And then the R is for mental retardation or intellectual disability. Transitional cell carcinoma also goes by the newer name urothelial cell carcinoma. This is the most common malignancy of the entire urinary system, as opposed to renal cell carcinoma, which is the most common tumor of the kidney itself. This can occur in the renal calyces, in the pelvis, in the ureters, and in the bladder. And this makes sense because where do you find transitional cells? In the bladder. Transitional epithelium is made up of layers of cells that allow the bladder to expand and contract. It typically presents with painless hematuria, and you need to know the major risk factors. Smoking, which is the #1 risk factor by far, aniline dyes, naphthalene dyes, and the chemotherapy drug cyclophosphamide. Cyclophosphamide can cause hemorrhagic cystitis and urothelial carcinoma. Another type of bladder cancer is squamous cell carcinoma of the bladder. This is also associated with smoking, chronic or recurrent urinary tract infections, bladder stones, which are kidney stones that end up in the bladder, and then cyclophosphamide and hemorrhagic cystitis. Basically, this is a situation where you have chronic irritation and inflammation of the bladder that gradually leads to metaplasia and then dysplasia and then carcinoma. It's kind of similar to how GERD leads to Barrett's esophagus and then esophageal cancer. Now, squamous cell bladder cancer is pretty uncommon in the U.S., but in the Middle East, where schistosoma hematobium infection is a problem, that's a major cause of squamous cell bladder cancer. And again, it's kind of like how H. pylori causes gastric cancer. Now it's time for the end of session quiz. So pause the video, work through those questions, then we'll go through the answers together. First question, what is the WAGR complex? WAGR stands for Wilms tumor, aniridia, genitourinary malformation, and the R is for mental retardation or intellectual disability. Next, what are the risk factors for urothelial cell carcinoma or transitional cell carcinoma? We mentioned smoking, aniline dyes, naphthylamine dyes, and cyclophosphamide. The last question, what genitourinary tract pathology fits each of the following descriptions? The most common malignancy of the urinary tract is urothelial carcinoma. The most common renal malignancy of early childhood is Wilms tumor. The most common type of renal stone is calcium oxalate stones. The type of renal stone associated with Proteus mirabilis is struvite stones. And the most common primary renal tumor in adults is renal cell carcinoma. That's it for now. I'll see you next time.